do expect more to join. But Stephanie, the time is yours, and I'll turn the time over to you.
Excellent. Good morning, everyone.
Oh, you're on mute.
No, I'm not. Okay, can you, everyone is good? Excellent. Okay. This hearing of the New Mexico Department of Health Medical Cannabis Advisory Board will now come to order. I would like to welcome you to the public hearing to review petitions requesting the inclusion of medical conditions or diseases to the list of debilitating conditions currently eligible for license under the Medical Cannabis Program. Also, during this hearing, the Medical Cannabis Advisory Board will hear information and issue recommendations concerning rules and the quantities of cannabis that are necessary to constitute an adequate supply. Pursuant to notice, this matter is being heard this 16th day of November 2020 via a WebEx events platform and is being recorded. The time is approximately 9 a.m. I am Stephanie Richmond, and I am a member of the Medical Cannabis Advisory Board. I will be managing the hearing today until a chairperson and alternate are elected. New Mexico Department of Health Assistant General Counsel Chris Woodward will be advising the department during this proceeding. This proceeding is being held in accordance with the Lynn & Aaron Compassionate Use Act, Sections 26(2)(b)(1) through 26(2)(b)(7), NMSA 1978, and regulations at the NMAC Title VII, Chapter 34, Part 2. If members of the audience have not already registered for this event, please register online so that your attendance may be noted and included with the Advisory Board's submission to the Secretary of Health. At this time, I'd like to ask each Medical Cannabis Advisory Board member to introduce themselves, announce their training and specialties, and highlight why they are interested in serving on the Medical Cannabis Advisory Board. We'll go in alphabetical order, and I ask that you keep your comments brief. Let's start with Ariel Bowers.
Hello, my name is Ariel Bowers. I am a registered nurse as well as a psychiatric nurse practitioner and a nurse midwife. I work out of Albuquerque, and my interest in medical cannabis really has to do with supporting my patients. I particularly work with a lot of folks who have trauma, and I also, one of my specialty areas is perinatal substance use disorders. And so there's lots of nuance to, how cannabis plays into like both relief of psychiatric disorders and then also plays into sometimes substance use disorders. Thanks.
Thank you. Is Kenneth Carraza available? All right. John Paul.
Hi, good morning. My name is Jean-Paul Dedam. I am a MD and family medicine specialty by training, although I work mostly now as a hospitalist. I also have, I'm also board certified in medical acupuncture, and I run a symptoms management clinic at New Mexico Cancer Center, where I do acupuncture and cannabis medicine. Thank you.
Thank you. Rachel Goodman.
Hi, I'm Rachel Goodman. I'm a OBGYN physician here in Santa Fe. I work with Christus, and I have served on the board now for about 4 years and have really enjoyed my time on the board. It's grown a lot and looking forward to where it could go. And I, don't always have a lot of very specific OBGYN related situations that arise, but occasionally we have one. So I still enjoy being a part of it and giving my input.
Thank you. Courtney Marquez.
Hi, I'm Courtney. I'm a physician assistant at the New Mexico Cancer Center, and I am interested in being on the board because I just wanted to be a part of supporting medical cannabis as an adjunctive treatment for our patients for their pain and and then just for and anxiety and just for the different things that it can be used for people and for patients.
Thank you. Davin Quinn.
Hi, my name is Davin Quinn. I'm a psychiatrist at the University of New Mexico Hospital. I specialize in the treatment of traumatic brain injury and other cognitive, behavioral, and emotional consequences of neurologic disease. Just very interested in this area of medicine. I think it's really, really exciting, really dynamic, and just excited to be involved in it. So thanks very much.
Thank you. Is Alan Plymel available? All right. My name is Stephanie Richmond. I am a physician assistant and I have been since 2005. I also serve on the New Mexico Academy of Physician Assistants Board, and I'm interested in participating on the board because I've seen how the medical cannabis has really improved quality of life for a lot of my patients, and I'm interested in expanding access to that treatment for patients. I'm excited to participate with all of you today. Next is Tracy White.
Good morning, everyone. My name is Tracy White. I'm a PharmD. I'm a pharmacist in Las Cruces at the MMC Cancer Center. I'm also a prescribing pharmacist as a pharmacist clinician. I have about 10 years of experience in hospice care. So that was really what sparked my interest in medical cannabis. And just to echo many folks that we've already heard, just wanting to advocate for patients for using this medicine and for advancing the role of the pharmacist. I'll take care of the dog. Thank you.
All right. At this time, we have 7 of 9 advisory board members present and therefore have established a quorum. We will now proceed with the hearing agenda. First item is nomination and election of a new chairperson. Election of officers shall be conducted as the first order of business. The advisory board shall elect by majority vote cast of the 9-member board a chairperson and an alternate. The chairperson or alternate shall exercise all powers and duties prescribed or delegated to them under NMAC 7.34.2.8. Nominations and self-nominations for these positions will be done from the floor. Are there any nominations for the chairperson? I'll nominate myself.
I'm happy to second your self-nomination.
Excellent. All right. How about, are there nominations or self-nominations for the alternate chairperson position?
I would be happy to take on that role.
Excellent. I second that. All right. So Stephanie Richmond will be the chairperson and Jean Paul will be the alternate. Thank you. Next is the Medical Cannabis Program update. For an update onto the activity and progress of the Medical Cannabis Program. Is someone? Yes.
Stephanie, yeah, we need the board to actually vote on both of those nominations for the chairperson as well as the alternate.
Sure. All right, chairperson election for myself. Any opposed? All are approval. It is confirmed that the vote is for myself. For John Paul, I'm sorry, can you pronounce your last name for me so I can say it correctly?
Yeah, Dedam.
Thank you. For the alternate chairperson, John Paul Dedam, I would like to ask members to vote. Any opposed? Excellent. We are all for. Votes have been tallied for each. Majority are present for confirmation of the chairperson and alternate chairperson. All right. Now we would be ready to hear from the medical cannabis program for an update.
Good morning. This is Dr. Dominic Zerlo, and I am the Medical Cannabis Program Division Director. And first, I would like to thank everybody for attending this meeting, especially to all of the Medical Cannabis Advisory Boards. And thank you for participating in this, to all of the patients and community members who are also joining us today. While COVID-19 has certainly changed the lives of New Mexicans, the New Mexico Department of Health and the Medical Cannabis Program, along with the many licensed nonprofit producers, have continued to try to provide services in the best ways possible. This has included ensuring that medical cannabis producers are able to reach patients by declaring medical cannabis as an essential service in the public health orders that have happened over the last 8 months. Now, as far as the program itself, even during the current pandemic, our patient count has continued to increase, and we have been able to continue to serve patients. As an example, on September 30th of 2019, the program had 77,168 patients enrolled in the program. As of this past September of 2020, there were 98,507 patients enrolled in the program. That is an increase of 27% over the previous year. And more recently, just so that you know, as of October 31st, 2020, we have now reached 100,021 patients enrolled in the program. As far as adequate supply, for the quarter ending September 30th of 2020, the number of plants that were licensed to be grown was 51,250. The number of mature plants which were in production was 30,264. The number of plants that were reported as harvested during the quarter by the licensed nonprofit producers was 21,279. This is a 40% increase over the same quarter in 2019, when there were 15,145 plants harvested. This indicates the number of plants that have been grown indicates there is still the possibility for the licensed nonprofit producers to grow approximately 21,000 more plants than were in production at the end of this past quarter. This is the same amount of plants that were harvested during the quarter, and when grown, would represent a very large increase over the current production. With this potential yet to be realized, the licensed nonprofit producers have reported at the end of the third quarter, and again, this is as of September 30th, 2020, that there was a total of 5,774,625 grams of flower and bud in stock, with an additional 3,617,266 units of cannabis-derived products in stock. As a comparison for the amount of medical cannabis in stock, at the end of the third quarter, 2019, there were just under 4 million grams of flower at 3.888 million. And as far as cannabis-derived products, were not accounted in the same way at this time, so I'm not including those in this report. The amount of medical cannabis currently in stock represents a 48.5% increase in flower and bud over the same time period last year. While state offices have been closed to the public since the implementation of the public health orders due to the COVID-19 pandemic, the program has continued to process applications, meet the statutory requirements for 30 days for approval or denial of a completed patient application, and mailing the patients their cards within the additional 5 days. Accordingly, the License and Compliance section has also continued to work through the pandemic to ensure relicensure of all of the licensed nonprofit producers, review amendments from the licensed nonprofit producers, also to relicense manufacturers and review their amendments as well. And in part, they have conducted site visits through virtual means when possible, and whenever safe and appropriate to do so, in person. In addition, the Medical Cannabis Program has been working with BioTrack THC to implement a patient portal where patients and providers will be able to submit their applications online. This has been delayed due to some of the impact of COVID-19, but is anticipated to be available to patients and providers soon. Again, I'd like to thank the board members, patients, and community members who are participating today, and I hope that everyone is able to stay as safe as possible during the current pandemic situation. Thank you.
Excellent, thank you. I also understand that there are some review of proposed rule changes that the medical cannabis program can give us updates regarding.
Stephanie, Stephanie,
Yes.
Alan Plymel has been able to join, and if we wanted to give him the opportunity to introduce himself, he is another one of our board members.
Thank you. Welcome, Ellen. Please introduce yourself, tell us your background and why you are interested in participating on the Medical Cannabis Advisory Board.
Okay. Since 1973, you have a Doctor of Pharmacy and a Doctor of Medicine degrees. Had my own business for many, many years, and then went back to medical school. Then I've been practicing with members of internal medicine for a number of years now. I am now working only 2 days a week there, so I have more time and figure this is time to give back, donate to worthy causes.
Thank you. All right. At this time, we will hear from the Medical Cannabis Program regarding any proposed rule changes.
Thank you again, Madam Chairperson Stephanie Richmond. Again, this is Dr. Dominic Zerlo, and as far as for the rules, and I know this has been sent to all of the board members and is available through the Department of Health website, as well as a summary of the rule amendment and the reasons for it. And this is for the Medical Cannabis Program Rule Amendment 7.34.3. And the basis for this is the New Mexico Department of Health wants to ensure residents of the state of New Mexico are seeking the medical attention which is needed and necessary for them to be enrolled in the medical cannabis program. This includes being under the medical care of providers in New Mexico. The proposed rules help to ensure that this is occurring, reduce confusion with regard to the current set of rules, and thus help to improve the health outcomes of New Mexicans who are enrolled in the medical cannabis program. This is important so that medical providers can ensure patients are not experiencing negative outcomes and/or the masking of more serious medical situations through the temporary relief of symptoms, which may be by the use of medical cannabis. So the proposed amendment to the rules would clarify the residency requirements so an individual who is a resident of New Mexico who is now a resident of New Mexico may participate in the regular medical cannabis program and ensure that they are enrolling through the program itself. It would also allow that reciprocal program participants provide that their place of residence is consistent with their place of enrollment. It would ensure the purpose of reciprocity, which is to allow individuals who travel from their home state or other jurisdiction or location may obtain medical cannabis during their visit to New Mexico. That when purchasing medical cannabis, individuals would need to verify, and individuals meaning at the point of sale, would need to verify that the individual who is purchasing medical cannabis is participating in the medical cannabis program where they are enrolled. This proposed amendment to the rules also clarifies the exception for New Mexico residents who are members of a New Mexico Indian Nation, tribe, or Pueblo medical cannabis program and their ability to participate as a reciprocal participant in the New Mexico Department of Health medical cannabis program. The proposed amendment would modify the reciprocal limit to 230 units of medical cannabis per year for reciprocal patients. This would allow for individuals who are traveling to and through New Mexico to have access to their medication during their travels throughout the state. The proposed amendment would modify the requirement and require the licensed nonprofit producer selling an individual medical cannabis as a reciprocal participant to verify the proof of authorization with the individual's place of residence, ensuring the individual meets the qualifications of the reciprocal program, and to record this information in the registration and verification tracking system. The proposed amendment would ensure the reciprocal participant is enrolled in a medical cannabis program from their originating state or governmental entity by providing proof from the governmental entity or agency of the participant's enrollment. This helps to ensure the medical practitioner is in good standing with their licensing body and that the reciprocal participant has met the eligibility requirements of the originating jurisdiction. Thank you very much. Back to you, Madam Chair.
Thank you. At this time, I'd like to open discussion to fellow board members regarding the proposed amendment and then move forward with a vote. Who would like to start?
Something. When we've discussed this in the past, I think this does make a lot of sense to have reciprocity. My question is on a logistics level, what you said at the end there is this involves the patient showing just a valid card? So does it fall on the, like at the time of sale, the bud tender checks an ID, make sure the date is valid, and then that's a go?
Essentially, that is correct. They would have to upload it into the registration system, but they would have to check for the individual's government-issued picture ID and their issued card for participating in a medical cannabis program.
So the person taking the sale at the actual dispensary is the one who is uploading them into the program.
That is correct, and that is what happens currently as well with regard to their registering into the program.
Okay. And do you know how many other states or most states with a medical program allowing for reciprocity at this time?
I do not know the exact number of states. We can get that back to the board members.
Well, it makes sense to me. I'm in favor of this amendment.
How did you come to the determination for the quantity for the reciprocity patients?
So what the program did is we looked at, as far as the idea behind reciprocity was to ensure that individuals who are traveling through the state would be able to have access. We also wanted to take into account that some individuals may travel through the state or stay, such as on vacation, for a few weeks at a time at different parts during their year. And the 230 units is the amount that patients, current patients in the medical cannabis program, may obtain in a 90-day calendar period. And if an individual is looking at staying in New Mexico for longer periods than 90 days, that would also allow them the opportunity to register, to become a resident of New Mexico and register within the program.
Thank you. Do any of the other board members have questions regarding this amendment?
My only other comment would be that since we're going to discuss the amount allotted per patient later on in this meeting, that perhaps we revisit the amount for this for reciprocity as well.
Hi, this is Davin Quinn. I have a question. Are there any potential downsides to adopting this rule change? It seems pretty straightforward and makes sense to me, but I just want to check to see if there's any potential downsides to
it. Thank you very much, Dr. Quinn. The aspects of this that some individuals would consider to be a downside is that individuals will have to be residents of the jurisdiction where they are applying. Part of the reason for this is because what we are seeing is a large number of individuals who are trying to register for a program in states where they do not even reside, have not visited, and so are not getting the medical care to ensure that medical cannabis is the correct medication for them. And so that is the main purpose behind this particular amendment. Thank you.
Thank you. Appreciate it.
I have a question. This is Ariel Bowers. So please correct me if I didn't hear this right, but is it a 90-day period there where people can be reciprocal patients in New Mexico? And at that point, they can no longer be reciprocal patients if they're out-of-state residents?
Thank you. I think I understand the question. If I don't answer it in a way that meets what you are trying to ask, please let me know. So essentially, if an individual is a resident of New Mexico, they will have to apply for the program through the regular channels. So seeing their doctor and submitting their application and then receiving their card as a medical patient in the program. An individual would not be able to be simultaneously a resident and a participant in the medical cannabis program, as well as being a reciprocal patient. So they would not be able to do both at the same time. And the reason for that is to ensure that they are not actually purchasing additional amounts and diverting.
Sure. And so the quantity limit is it sounded like it was a 3-month quantity limit. Is that right?
That is correct.
Okay. And then beyond that point, beyond that 3 months or that quantity limit, then what happens?
If they reach that limit, then they have not become a resident of New Mexico and enrolled in the New Mexico program, then they would not be eligible at that time to continue receiving or purchasing medical cannabis until the full year has passed to their registration. And then they can register again and receive that. Okay.
I'm concerned just because of the COVID pandemic. You know, I am seeing a number of people that have been displaced in different ways, you know, have come back to New Mexico to care for family members or, you know, have some transitional period of time where they don't know where they'll be living. And then also I have some concern because of college students, you know, who for different reasons may have, have been displaced because of the pandemic. It seems to me that that quantity limit, that 3-month kind of quantity limit may not be reasonable for a lot of people at this point.
I'm sorry, did you have another question on that, or were you just making that as a statement to the board?
It's a concern that I have. Do you think that there would be a possibility that we could adjust that? Or are we really just looking at a for or against vote for this policy change at this point?
This is Alan. I wanted to interject one other issue with snowbirds that come down to the sunny Southwest for 6 months out of the year. And is there a way to have this where they can do their 90 days and then have another 90-day renewal without changing residence because they're going back where they normally live?
Under the current proposal, it would be the 8 ounces per 90-day, or the 8 ounces in the year period. And again, one thing to note is that when we look at the number of patients who even approach the full limit, it is less than 50 individuals, and that's out of the 100,000 patients that are currently in the program who reach their limits.
I know that per part of the rule as it stands, people who need to have greater quantities, maybe because they live in a super rural area, can have that, they can apply for that through the Department of Health, correct? Where they can expand like the amount that maybe they get at one time? Is that right?
That is correct. So individuals currently in the program can receive up to the 230 units or 8 ounces in their 90-day period. However, they also can request an additional 4 ounces added to that 90-day period if so needed and under the direction and advisement of their medical practitioner.
Okay. And is that, does that also include like the reciprocity patients or no?
No, not at this time.
Okay.
So it seems to me that the main issue with the reciprocity is that we're having people from outside of the state who are spending more than 3 months in New Mexico because they're students or they are they're either students or snowbirds. Is there some? It does seem like that is a bit of a shortcoming for the rules as it stands. I'm not sure how many people that's going to affect, but I mean, I think people have already come up with a number of examples where people would end up. It sounds like people would end up being cut off after 3 months. Is that correct?
After 3 months, they would not be able to continue purchasing until then. However, that is not the vast majority of the reciprocal patients and participants that we are seeing enrolling in the program. And the idea behind this is to reduce the potential for fraud and relieve the burden from those individuals at the point of sale for having to verify who is actually able to, for example, in another state, is actually able and licensed within that state to be able to issue letters for individuals.
So why the difference, I suppose? Why not have them be treated along with our state rules? So why or say my proposal would be, whatever we decide, especially later in the meeting, the allotment, why make that the reciprocity residents, whatever that ends up falling at?
That is actually what is occurring currently. And due to that issue, what is happening is patients are actually bypassing the regular system and therefore not seeking necessarily the medical advice of their practitioners. And the program wants to ensure and needs to ensure the health and safety of patients. And part of that is to ensure that they are actually doing this under the advice of the medical practitioners. And again, the reason for the difference in the units is simply because this was meant to be a program. The reciprocal portion was meant to be for a program of individuals who are visiting the state, not who are staying for longer periods of time.
Maybe that part I'm confused with, because we need to assume that if they're an active member of their program in their home state, that they are under the care of a physician, and that we are allowing them to continue to receive the medication while they're visiting our state.
Let me clarify that. Part of what we do currently is the current rules allow for the 8 ounces in the 90-day period. And instead of doing that, because it is the same amount, we see individuals who are simply enrolling as reciprocal participants rather than going through the full process of enrolling within their jurisdiction, because the amounts are the same. And to them, they are perceiving no real benefit in seeing a local provider. And so that is why, both with regard to the change and understanding that the individual has to reside and be within the jurisdiction where they are enrolling. So, for example, right now, individuals are going online to see a medical provider in California, and in less than 10 minutes, as they advertise, the person can get a letter of recommendation and then take that into a current dispensary to purchase cannabis. And because the limits are the same, people are doing that, including New Mexico residents, rather than enrolling through the regular program. So they're not getting the standard of care that we would expect for patients and participants within the program. And that's where our big concern is, as they may be masking symptoms of more deleterious or damaging conditions without really being under the direction of a medical provider. And we want to ensure that that happens. And so that is a part of why the limitation being present of the 8 ounces in a 90-day period, to ensure that visitors in the state are able to obtain their medical cannabis, and that individuals who are staying in the state for a longer period still have the option to enroll within the program to be able to receive that while still under medical direction of a medical provider. I hope that helped clarify that somewhat, and the reasoning behind this.
Yeah, a lot, thank you. There's a loophole basically that we're trying to close.
Exactly. And so what we've seen happen are patients, including patients in New Mexico, who rather than seeing their provider and getting not just a medical cannabis visit, but actually seeing, getting a full physical or a full visit to discuss their issues and concerns, are simply going through a process online where somebody essentially asks them and says, do you have these symptoms on a checklist? And then sends an electronic letter to them. This is not up to the standards that we would consider from the Department of Health to be a medical visit. And what we're trying to do and attempting to do through this is to ensure that the patients who are enrolled in the program are getting the medical care that they deserve and that they need.
Great, thank you.
I agree with being able to address any of the loopholes. I also hear what Rachel was saying in terms of, it does seem that the quantity might be a separate issue, and that is also a large portion of other items on the agenda today. I also understand that Kenneth Coraza has also joined us as an advisory board member. I'd like him to introduce himself to the rest of us, give us information about your background and why you're interested in participating on the board.
Mexico. I think it's a worthwhile project. I agree with Dominic about what he's saying. There are loopholes that we're just trying to make sure that the patients receive the care that's needed. Did that go through? I'm sorry. Yes.
Yes, thank you.
Okay, sorry.
All right, so how would you board members like to proceed with this? Do you want to put the reciprocity amendment rules to a vote now? Do you want to table it until later in the meeting after we have some other discussion about some of the other petitions that are presented to us?
This is Ken Perez. I would like to have a motion to say that we follow the current regulations in place and not postpone it till later. We have a vote on the amount later.
That would be to adopt. That would be to adopt these new amendments. I would second that if that's what Ken means.
Okay, part of my concern is that part of the amendment included some quantity limits. And if we approve it now, then if we have questions about quantity limits that come up later in the meeting, that would be, I'm not saying that we're tabling addressing the amendment rules until another time, but maybe getting some other additional information about quantity limits that are already on the agenda.
Yeah, I prefer that we wait to vote until after the quantity discussion.
I withdraw my motion.
All right.
Same here.
Excellent. Thank you. All right, so we will table the proposed rule changes until later today in the meeting. Let's move forward with some consideration of petitions. Applicants have been informed in advance that their petition would be heard today. The petitions have been redacted to protect confidentiality of the applicant. However, applicants were informed that they may speak directly to the board if they request to do so in advance. If any applicant has made such a request, the board may go into executive session to hear the individual applicant. Only those confidential issues related to the applicant's health status may be discussed in a closed meeting. If we do go into a closed executive session, a separate breakout session will be created and board members will leave this meeting to discuss items in a private, non-recorded setting. I remind those presenting positions today that this hearing is being recorded. Before you speak, please state for the record your full name and whom you represent. All advisory board members have received copies of the petition, so I would ask that the presentations be kept to less than 3 minutes unless new information not included in the original petition is being presented. If new information is being presented, please limit your presentation to 10 minutes. Any petitioner who wishes to submit evidence with their petition may do so when they are recognized to present. At that time, those exhibits will be numbered and entered in the record. After each petitioner has presented, I will permit the members of the board to question the petitioner. After the board has had sufficient time to discuss the petition, I will request that the board move to vote on petition being considered before moving on to the next petition. Public comment will be available at the end of the meeting. Pre-registrants will be able to comment first and should limit their speaking time to 3 minutes. If you have not registered, please click on the raise hand icon if you are using a computer or dial #3 if you're calling in by phone. For those of you unable to make a public comment during the meeting, the public comment period will be open for 48 hours after the meeting. Please send all public comments to the following web address: medical.cannabis@state.nm.us. The board will begin by accepting statements from petitioner applicants only. Does the petitioner for petition 2019-008 add ADHD, ADD, anxiety disorder, and Tourette syndrome wish to present?
Mr. Barker, go ahead.
Yes, can everybody hear me? Yes, this is Jason Barker. The new information I want to provide with this petition, ADD, ADHD, anxiety disorder, and Tourette's syndrome are all rapidly increasing in people during the current pandemic. There's a team of Italian researchers and doctors working on that research right now to figure out how bad this is getting for the number of people with those health conditions. And I'm sure this is something we're seeing increase in our state due to the pandemic as well. And then I just wanted to point out within the petition that you all have is a comprehensive list of all the state medical cannabis programs already doing these health conditions in their medical cannabis programs. Several of these states are new medical cannabis programs that have only been around for a couple of years. There was a period 3 or 4 years ago, New Mexico was considered a leader among the medical cannabis programs in the country. And it would be great to see us get back to that by having the same health conditions that other states have as well. Thank you. And if anyone has any questions, please feel free.
Thank you for the presentation. I also understand that the board has been in receipt of a letter from the New Mexico chapter of the Academy of Pediatrics. Just wanted to make sure that all of the other board members had been able to review that information. If that person would like to be able to present at this time to also share their views, I think that that would also be a reasonable time to do it. All right. So how does the board feel about having this petition being approved or denied, modified, tabled?
This is Davin Quinn from UNM. May I ask a few questions?
Yes, please.
Hi, thanks, Mr. Barker. I just want to clarify for the petition, is the use of medical cannabis for this meant to be for patients who have ADHD or ADD plus anxiety plus Tourette's, as in you have to have all three, or you only have to have one out of the three? Can you just clarify sort of what exactly is the qualifying set of conditions?
These have all been done separately in separate petitions in previous years, and at which time the Medical Cannabis Advisory Board voted to approve these into the program, but it was rejected by Secretary Gallagher at the time. So I've just put them all into one petition to simplify, because they are all very similar health conditions in nature as well, and with research that does involve both conditions in the petitions.
I see. So this is actually three separate conditions and would be three separate qualifying conditions?
Yes, very similar to a previous petition that added 3 neurological health disorders into the program that was done in one petition.
I see. Great. Thank you. And one other question for the ADD, ADHD indication. What exactly is sort of the rationale for improving or using medical cannabis? Is that to improve attention or attentional capabilities? Because I guess my concern is that medical cannabis can have, or cannabis in general can have, sort of deleterious effects on attention and cognition. So would you be able to speak to that, please?
Yeah, I mean, with that, for myself, I am one that has Asperger's, and for me, the medical cannabis helps a great deal with concentration. And, I think in conjunction too with pharmaceuticals with a lot of these health conditions, that's how we're seeing a lot of health conditions being treated in our program, where we're not seeing it fully being all medical cannabis being used. And so this is something that enables another tool in the toolbox in the treatment. And if it can reduce the use of pharmaceuticals, that's even better.
Okay, thank you.
So I've done some research on this myself, because it does, kind of echoing what you said, Dr. Quinn. It seems like in many ways cannabis would not be the ideal medication for a patient on ADHD, but interesting. I mean, he does have this small, there is included a small study that shows improvement in both decreasing activity, which makes sense because anandamide in the brain in the striatum is going to decrease your overall. That's probably where you get the decreased activity with, as far as like couch lock phenomenon, and for some reason does seem to improve the cognitive score. Interesting. So anandamide, which is the endocannabinoid equivalent of THC, does decrease dopamine transport function in the brain, which is exactly what other ADHD medications, such as mostly stimulants, that's the effect that they have as well. So decreasing the excessive amount of dopamine in the brain. And there was another study that came out in 2005. It was in mice. Unfortunately, it shows that via another receptor that THC can decrease hyperactivity in mice. So I think that, unfortunately, the issue is that we don't know exactly what causes ADHD. We have some idea of the underlying mechanisms, but we don't know exactly. And the other thing is that ADHD is more than likely not a single clinical entity. It's probably multiple different conditions. And I think there's some indication that some of those conditions are benefited by cannabis, some are not. But I think given the evidence in adults that there is some clinical, some basic science understanding of how this could possibly help, that I think that it should be included. My major concern and possible consideration for a modification would be that, the small study we have is in adults, it's not in children, and that we don't know the effect that chronic cannabis has in children. It does appear to affect their neurodevelopment. ADHD untreated is going to affect their neurodevelopment as well. Adults have compromise, have smaller cortical executive functioning areas. But, given that I think it's reasonable to allow this for treatment of adults, but I would say that maybe a modification I would suggest would be to carve out to say that it should not be used. This should be used only in adult ADHD and not children. So that's my piece.
Thank you, Dr. Dadam. If I could follow up on that, I share your concern about the use of this for pediatric ADD or ADHD, just because my awareness of sort of the literature there is that anywhere from 30 to 50% of cases or patients who manifest or have been given a diagnosis of ADD or ADHD as children, when they get admitted to a psychiatric facility, the signs and symptoms of ADD or ADHD seem to disappear just simply with a change in environment. And so given that, and given also sort of the concern about neurodevelopment and also increased risk of emergence of psychosis, I would definitely be in favor of that kind of a modification.
I agree. I think that it's not inappropriate to have this as a potential tool for adults with ADHD, but I don't think it should be approved for kiddos.
So it just comes a lot in some petitions that aren't clarifying adults versus children. And so that was the intention of this petition to be for adult ADHD, or did it include children as well? And I would be in support. Every discussion that we've had in the past is not to support the use in children and approving it. So I don't know how maybe the petitioner could clarify if this is for adults, or if we could add that as a modification to the petition as well. Maybe Dominic could speak to that, how the best way to go about doing that.
The board would just have to modify the petition and send it, when the recommendation is made, make the modification at that time frame. But you'd have to make a motion to modify and then vote on that modified motion.
All right.
So are we having to vote to modify the motion for ADHD and then also vote to accept Tourette's and anxiety as well as approved conditions? We only have to do one separate vote with the modification for the ADD, is that correct?
I suppose I would make the motion to say that this, I would approve all three conditions, but only for treatment of adults.
So based on what Gary just said, I would motion to modify the petition to only include adults.
I approve that motion.
Okay, all in favor?
I'm sorry, may I ask one more quick question? So currently there's a qualifying condition of post-traumatic stress disorder.
Yeah, exactly.
And would the anxiety disorders, which I assume would cover all anxiety disorders in DSM-5, would that subsume PTSD under it, or would that still continue to be separate? I'm just not sure if we need to address that or not.
I mean, that is one aspect of concern with that is we already have people getting medical cannabis cards under two big umbrella terms in the program under chronic pain and PTSD. And these are all also correlating health conditions with PTSD as well. We have pediatric patients that have PTSD cards, and they should rightfully be allowed to do so. And the intent of this is to be open for everybody who is able to get a medical cannabis card in our state. And I point out in the petition, it does mention beneficial cannabinoids through some of the research, and a big part of that is using CBD in conjunction with THC. And so this isn't just people accessing all THC products to treat these three different health conditions. And, pediatric patients in other states that are in programs for Tourette's or ADHD, like in Ohio, their parents are most certainly using one-to-one products, using mostly cannabis-derived CBD with a little bit of THC maybe in the evenings. So, I wouldn't be opposed to seeing that being changed to all adults, but I would like to also see, further discussion then down the road about this, as a pediatric accepting qualifying condition as well. There's no reason we need to be limiting our health conditions unless you're going to go back through all the health conditions and say, wait, is this adult only and this isn't? Because that's completely changing how we've been doing things in the program for years.
I understand that. I hear what you're saying. It also seems that board members are concerned about the inclusion of the medical cannabis use with the pediatric population for that diagnosis of ADHD, from what I am gathering from my colleagues.
Yeah, and like I say, I don't see that as being a, destroy the whole petition, vote it down. Because of that, we can, if you want to make that modification, that's fine here in the time. Like I said, I just like to hope everybody, keeps open mind to seeing that again in the future. Then, just to give you a little history on myself, I've done over 65 petitions since 2017 through the Medical Cannabis Advisory Board. Many times I've had to do them multiple times to get the health conditions approved, to get us equal with other states. So I don't understand some of the apprehensiveness when we already see this in other states, but, we're glad to work with the situation and try and keep an open mind down the road for some forward thinking.
Madam Chair, I move to modify the petition to be for adults only.
Is there a second?
And for which conditions?
I was meaning for all of the conditions. For the three that are in the petition.
I'll second.
That's Rachel.
All right. So it has been approved to allow ADD.
Now we need a vote.
All right. For the vote of the members, for the options are approve, not approve, modify, or table. We have had a motion to modify the petition for adults. How does Ariel Bowers vote?
Yes.
Kenneth Carrazza. Jean-Paul Dedam.
I vote to approve the modification.
Rachel Goodman.
Yes, I seconded it.
Courtney Marquez.
Yes.
Alan Flymo.
Yes.
Davin Quinn.
To modification.
Stephanie Richmond, I also approve the modification. Tracy White.
Yes, approve modification.
Excellent.
You can try Dr. Carrazza again. I just unmuted him.
All right. How about you, Dr. Carrazza? How would you like to enter your vote?
Yes.
Perfect. All right. We have all agreed to include the petition for inclusion of ADD, ADHD, Tourette's with the modification that it be for adults.
I think we just
time.
Now we have to vote on approving the petition. Is that correct?
That's a good question. Guidance.
I'd like to move to approve the petition with the modification.
Yes, I believe the board has approved the petition with the modification.
So it was okay to do it all in one vote, Gary?
Yeah, that's nice.
Yes.
Okay.
Yeah, perfect. All right. So now let's move on to the second position on the agenda for the 2019-009 add substance use disorder. The board will begin by accepting statements from the petitioner applicant. Would they like to present at this time?
Yes, just have a few comments. Again, this is Jason Barker. Recently, the Department of Health reports drug overdose from prescription opioids have declined, but illicit substance overdoses sadly have gone up. In 2019, New Mexico added opioid use disorder into the state's medical cannabis program. Hopefully, that's why we have seen a decline in those opioid overdoses. However, total overdose deaths among New Mexicans rose 13% in 2018 and in 2019, and that exceeds the previous high from back in 2014. Methamphetamine was involved in 44% of all the drug overdose deaths in 2019. The percentage of overdose deaths that involved fentanyl went up 21% in 2019, up 13% from 2018. So my hope is that the approval with this petition that has also been approved in the past is to add in the other substance abuse disorders into the program so individuals can seek treatment just like those who have been abusing opioids have been able to do as well. Thank you.
Thank you. Does the board have any questions for the petitioner?
So I'd like a little bit of historical context here. Like, I know that in the past there has been, like, this has been brought up before, and then the response from the DOH has been, you know, well, what about, you know, like, maybe we need a little bit more clarification. Can other people who've been here longer, or like some of the other folks, like, chime in as to how this has been approached in the past?
I know we have heard it in the past. I would love as well a reminder as to what the past discussion was or the vote at the time.
I mean, I think, again, having like such a blanket diagnosis, like substance use disorders in general, is tricky, because if you're looking at the evidence, like there's not a lot of research that I found regarding amphetamine use disorder and medical cannabis. And I know that these studies don't necessarily get funded very often, and that is part of why the literature is sparse. But I do think that having some context would be useful. And then also, like, you know, there's a cannabis use disorder. I mean, and also there's, like, if you look at the DSM-5, like, there's caffeine use disorder, and there's, you know, like, so many like things. And so it doesn't necessarily make sense for me, like, thinking about like the very broad inclusion of substance use disorders as such a blanket diagnosis. But again, if there's more context, I would love to hear it.
Yeah, well, it's to include alcohol use disorder, tobacco use disorder, stimulant use disorder, hallucinogenic use disorder, and then OUD, which is already now in the program. And part of the discussion in the past amongst the board members had been that, yeah, when the approval of OUD went through, what we're treating there ultimately is the addiction aspect to the opioid. That's the same addiction aspect that the alcoholic is going to have, or a person who is smoking 5 packs of cigarettes a day. And then another point to make is there's also an active treatment center in California called High Sobriety, treating substance use disorders with only cannabis. So there is up and running clinics actually doing it that are working.
This is Davin Quinn from UNM. I share the concern with Dr. Bowers about the lumping together of these disorders that all have very different pathophysiologies. Alcohol use disorder withdrawal, involves a significant sort of glutamatergic surge, which can lead to withdrawal seizures. And while on the one hand, opiate withdrawal symptoms might be able to be managed, or craving might be able to be managed, and alcohol craving might be able to be managed with cannabis. I'm just concerned about what potential is there for people to think that they could manage frank alcohol withdrawal with this, with medical cannabis, and put themselves at risk.
And I think that, this is Ariel Bowers, I think also that in terms of available literature, like the inclusion of opioid use disorder, which is already a condition, like makes more sense to me, because there is so much more robust evidence in terms of it being useful. And cannabis, you're right, like there are some dopamine centers that get hit with cannabis, but there's also like it indirectly affects the opioid system. And so the pathophysiology kind of makes a little bit more sense as to why it helps. But then, I'm also concerned because, often often you're looking at polysubstance use disorders, right? You're looking at multiple substances. And I am concerned about people not being able to seek appropriate treatment, and using cannabis in ways that is not helpful to them in terms of their overall recovery longer term.
I totally agree that these are very different conditions, and we don't have very much evidence as to whether cannabis would even work. I think the argument of harm reduction, of using this as a harm reduction model, I think is interesting, though, because the addiction potential for cannabis is much less than with many of these other, don't have the potential for fatal overdose. But that being said, I think that I don't know. I think that addiction is not just about giving somebody a medication or having them use a medication that's going to make them feel better. Addiction requires counseling and other services, and I think the big concern, I think, from the board is as the petitioner referenced, I'm perfectly fine with this being used in California in the setting of supervision and counseling and other services. And I worry, as Dr. Quinn expressed, that this may be people just using, doing this, trying to treat their addiction, their substance use on their own. Same as Ariel brought up, that I don't know, that I feel like that is probably not how I would want to see. I think that cannabis potentially could be used in this fashion, but I don't think that we have the infrastructure here to really support those patients. And maybe then we get into a chicken or the egg thing. If we don't approve this, then how is somebody going to start a program to to use this as a treatment tool? How is somebody, but I don't know. It's a tricky subject. I think there's potential there, but I don't want patients treating their own addiction at home unsupervised in potentially dangerous situation.
Thank you. If I can just follow up on Dr. Dedom's comments. To me, alcohol use disorder among that group of disorders that are listed in the petition is somewhat different. Tobacco use disorder, stimulant use disorder, hallucinogen use disorder. I think for stimulant and hallucinogens that we don't really have any treatments for those disorders. So harm reduction in that context, I can sort of see that there is a role for medical cannabis. Stopping stimulants, stopping tobacco use is not going to lead to a fatality. alcohol use disorder to me seems to be different. We have formal detox programs for alcohol withdrawal. And while I completely agree that there may be a role for this, I'm just not sure that that lumping all of those disorders together would be the best way to go about approving the use for each of these. So that's my concern. And if I were to suggest something, I might suggest modifying the petition to for not for alcohol use disorder, but for the tobacco stimulant hallucinogen.
I was going to recommend that myself as well, but with some of the alcohol use aspects, I was going to see if it would, be more welcoming to the board if maybe you altered it so that the person coming in with the recommendation for like AUD or cocaine or something else is in treatment with an addiction specialist of some sort, psychiatric nurse, specialist doctor. And if that could be a stipulation added in, that might be enable that, tool to be used down the road, like you said, because we certainly don't have the infrastructure for a lot of things, unfortunately, in our healthcare system in New Mexico. And this is one of the ways to help foster that activity. Thank you.
Could the petitioner speak more to what you just mentioned in regards to having it be like two co-signers, essentially? I mean, didn't we used to do that for chronic pain, and then that was something that went away? I mean, if this is something that, just putting that out there. I think that sometimes that just puts a different kind of a requirement for the patient that I don't know if that's something that's helps to streamline the process of the application.
Definitely, and not necessarily like, a two signature situation, but more, I would imagine a person, arriving at this situation, considering cannabis, with being in consultation with someone who is addiction specialist in the medical field versus someone who's just, gone to a clinic to see a nurse about a cannabis card or a general practitioner physician. Because if you're dealing with addiction, you're going to be seeing doctors at a much higher level, just like a person with a neurological disorder would be, or a cancer patient. And so, a lot of those the health conditions in the program, the cancer doctor treating the cancer patient is doing the recommendation for the card, and not just, a medical cannabis card clinic per se.
I appreciate the petitioner's suggestion. My one concern about that is I'm not sure how many addiction specialists there are in the state. I would be concerned about them being sort of overwhelmed by the numbers of folks who might be seeking them out for that purpose. But certainly I appreciate there being sort of an added level of monitoring, perhaps for. So is that just for the board? Is the opioid use disorder, does that require co-signing? Is that what someone had mentioned earlier? No.
The opioid does not require a second signature.
No, yeah.
In the interest of time, I would say I would like to make a motion to modify the petition to be for tobacco use, stimulant use, hallucinogen use only.
I would second that.
All right.
I'll second it.
So, all right, thank you. I understand that there has been a motion to modify to include the tobacco stimulant and hallucinogen by Dr. Quinn. Dr. Dedam has approved it. At this point, the board could move forward with doing a vote regarding this petition. So for the petition, we can either vote to approve, not approve, modify, or table. Let's start with Ariel Bowers.
Approve.
Do you approve with the modification or approve with all of the diagnosis in the petition that were presented?
Yes, with the modification.
All right, thank you. Kenneth Carrazza?
I approve with the modifications.
Thank you. Jean Paul, you had seconded the modification, so I am going to say that is your vote. Is that correct?
Yes.
And Rachel Goodman?
Yes, I approve the motion with the modification.
Courtney Marquez?
I approve the motion.
Ellen Plymall?
Approve with modifications.
Davin Quinn?
With
You
modification.
approve. I also approve with modification. And Tracy White?
Approve with modification.
Excellent. Thank you, guys. All right, so that is our second petition. Let's move on to the third one. Next up is the statement for the petitioner from the application for 2019-010 to add medical cannabis therapy for seizures in animals. Would that petitioner like to present at this point?
Yes. Again, this is Jason Barker with this one. Pull up my notes here. And now the biggest aspect with this petition is something I've been working actively with the veterinary medical board with, and the dog in question in the petition, Tecumseh, my dog, his veterinarian is a doctor on the state's veterinary medical board. So you know who in the state is aware of a dog getting cannabis for epilepsy. Tecumseh's case is rather unique. Not only does he have epilepsy, we just found out 3 weeks ago he has Cushing's disease as well. He takes currently right now the pharmaceuticals would be levetiracetam, phenobarbital. He takes zonisamide. Then he is on potassium bromide. And he also uses midazolam as a rescue for his seizures. Very powerful drug. Clorazepate, another very powerful drug. He's had 3 different vets suggest that he be put down already. Now, that's the difference that the cannabis does in animal seizure therapy. The medical cannabis products that I provide him, which is a tincture from Southwest Wellness that's 1-to-1, tincture from Ultra Health dispensary that's also 1-to-1, and a CBD tincture. And then additionally, I use medical cannabis tablets that you can only get in the medical cannabis system. That is something particularly the veterinarians are very interested in, because these are precise tablets with exact dosing, 5 milligram of CBD or 10 milligram of CBD. And what this does for the animal with the seizures is it provides that quality of life in conjunction with the use of the pharmaceuticals. And then by having the animal obtain a medical cannabis card as the person being a caregiver, this is helping the veterinarians in the state, because they are seeing a lot of toxicity issues of people getting hemp CBD products that are just barely regulated at all in the state. And they're being told, hey, you can stop your dog's epilepsy with this, and then their animal's getting sick. And then on the other side of it as well, it also helps people understand what they need to be doing by talking to their veterinarian with these conditions. And I'm glad to answer any questions. Thank you.
have a question. This is Ariel Bowers. Do other states include animals and veterinary science in their medical cannabis programs?
Currently, the state of California, their veterinary medical board is working on the rules to enable this to happen right now. Up in Colorado, the veterinary medical board is just taking a stance of, no comment really, and they're allowing it to occur. So as far as issuing an actual card to an animal, no. Other states are enabling it because both Colorado and California are states that have recreational cannabis as well. Now that is something that is also inevitable in New Mexico's future, it looks like. But the problem for New Mexico is they're going to use our medical cannabis program to support a legalization law. So without a specific medical card, these products may not be available. And that's why we need it that way.
You mentioned that you had been working with the veterinary board regarding this. What kind of feedback had you been getting from that board regarding this?
Well, that was the first step I approached. And what I had to do is initially, the way the rules and regulations for veterinarians were written in the state, they were not able to discuss with animal clients and their pet owners, even the use of simple hemp CBD products because of how they had the rules written. So I've gotten them to change those rules so the discussion could be enabled. And then the next step is based on our current medical cannabis program law, really there is nothing that would stop a veterinarian to sign a card, but they're more so looking for the reassurance of the program, the condition being in the program so that they know they've got that protection like the other doctors do.
I have a question. Who is going to sign off on this card? I mean, is this? It's not going to be veterinarians. I mean, if somebody came to me with with a request to sign off on their dog, I mean, I'm not qualified to do that. I wouldn't sign it.
No, they would go to a veterinarian. They would go to a DVM.
Oh, okay, so the vet is the one who signs it, not okay. That I was confused about that.
Yeah, I mean, the veterinarian is the only one in the state that can discuss any kind of medical treatment with animals. Anyways, it happens a lot. Where dogs get their haircuts and stuff like that. But it relates to vets, and this is designed to go through the veterinarian. Just like we were talking about earlier with having the patient go to the doctor for their treatment as a person.
This is Ariel.
Oh, sorry. Go ahead, Ariel.
So my question just has to do with, have you spoken with dispensaries about this, and what is their feedback in terms of, the medicine that they might have available that would be appropriate for dogs, and what is their perspective on this?
In talking with a few dispensaries, I mean, for them, it enables an entire new market to be developed. Just like a recreational law would, opening up dispensaries to the general public to buy anything in their stores. But for them, this opens up a market where, they're mainly going to be communicating with doctors of veterinary medicine as well that may put in requests for purchases or clients coming in and such a thing like that.
I imagine it would be a little bit of a learning curve, but interesting. Go ahead. I'm sorry.
And you can also bear in mind now, the people in the medical cannabis dispensaries can't give any medical advice to the people patients, and that would be the same for animal patients. I mean, it does go on certainly, but nobody really does have that training to do that except, unless there's a medical professional working at the dispensary.
The few comments I have, it seems that we would, if we approve this, we'd be paving the way and being the first state to have this. And not that I'm opposed to paving the way and doing that, that's fine. But, we're approving it, sounds like, for seizure disorder specifically as a foot in the door. And my guess is we'll start to see a lot more come down the pipelines and start to be making more and more decisions on approved disorders for veterinary medicine. So this seems to it would open a door down the road, and then maybe we need to be working more with the vet board, or have a member of or have an actual vet on the board to help contribute to this, so that we can know more about the literature around it for animals.
Well, most certainly, and definitely, point out that a lot of the research done that has enabled the medical cannabis use for a lot of the different health conditions in people has been done on animals, and has been done on dogs more specifically for different kinds of seizure treatments, whether it be epileptic or neurological. And what made me first come up with this idea was a neurological researcher up in Minnesota who was doing epilepsy research on dogs. And he was so impressed with what he was seeing from the cannabis treatment on dogs that he started initiating the process in Minnesota as well. And that should be mentioned in your petition you have for this. Dr. Lepke, I believe is his name.
And sorry, once again, how is the vet board that you were speaking of feel about this? Is there something that they're wanting, that they feel is a gap in their care?
Or it's something that otherwise for them they would have to address with a statutory change, but the way the medical cannabis program is structured, we have the ability to add these health conditions in right now. And like I said, ultimately there's no limitation preventing a doctor from doing so, but most doctors would feel better seeing this added in as a condition, because like when my doctor signed for my medical cannabis card, the state affords them certain protections.
Right.
And that would be the same then for a DVM. And this is specific to the DVM as well. So it's not like a veterinary assistant or, someone could just walk into a veterinary office like, here, can you sign that?
Would that be better suited to have an amendment made to the rules to include vets as providers that would be able to sign the medical card, rather just like as a PA, I'm included in the state to be able to do that, rather than going through this caregiver petition? Kind of wondering if that, because I also had the same questions that John Paul brought up about, my understanding was that the vets can talk about it. So then I understand that vets are wanting to have the same kind of protections that other people that are prescribers for the program. But does that still mean that the vets would then have to either get included into the rules to be qualified providers, or the vet would somehow have to give us a letter saying that then us as a provider are doing it? I just have a lot of questions about the logistics of how this actually would get executed.
This is Tracy White. I just wanted to comment that kind of like with prescription drugs, there's no guarantee that the owner is not using those prescription drugs. So, that I have a concern that could be the case if we don't have any way of guaranteeing that it is being used for the animals. And then what liability does that place on the vets?
I just want to point out about the comment was just made. You got to see the look on the faces of the people in the pharmacy when I show up to pick up midazolam and clorazepate, and they know I have a medical cannabis card. I've definitely gone through that scrutiny of them assuming, oh, this guy's getting this for himself and not his dog, and these are pharmaceuticals. So there's a two-way street there, and it's something the medical cannabis patient already deals with. But we don't have any protections there like we're talking about for the veterinarians. And I think, the amendment of the rules there, I think that would be beneficial. And like you're talking, that would provide clarity in the rules so the DVM would know, hey, this is an option if you don't need to go through with the caregiver petition. And that's all I have. Thank you.
One other thing of a concern, again, we're going to discuss this next, is the issue of adequate supply for the patients that we already have enrolled in the program. So if we expand to include however many animals there are, while we're not able to provide enough supply for the patients that we have in the program already for people, then I think we need to take that into account. If we're going to approve this, that's going to have to be taken into account in our next discussion as well for adequate supply.
I agree, and I agree with what you said earlier, Rachel, about wanting to be able to have this kind of conversation with somebody that's from the vet board themselves, if we're talking about different boards within the state. I agree with that.
We could table these, potentially, and have that discussions. I know we have another meeting soon, so it might not be tabled for too long, and maybe perhaps we could reach out or have a letter in favor of or against from the vet board would be helpful.
I agree with that. At this point, I move to consider tabling this petition until a future point. If anyone would like to move forward with voting on approving, not approving, modifying, or tabling this, we can move forward with a vote on this petition if you guys would like.
I'll second your motion to table discussion.
All right. Ariel Bowers, what is your vote for the seizure in animals?
I agree to table.
Kenneth Carrazza.
The gentleman is giving the dog all the drugs necessary for seizures, because I have several patients doing that. I have to disagree with him. I don't know anybody that comes in my store has a medical card. He's saying we look at him suspiciously. I think it would be best to get a letter from the veterinary board, seeing what their feelings are. So I vote that we table this for the time being.
John Paul.
Yeah, I'm very sympathetic to treatment of animals. Once again, outside of my area of expertise, I agree with bringing in the veterinary board and figuring out the correct the solution here. Table.
Rachel, you mentioned table before. Courtney Marquez.
I agree with tabling this for now.
Alan.
Agree to table with all the same concerns.
Davin.
Agree to table.
I also table. And Tracy.
Agree to table.
Excellent. All right. Thank you very much. Now let us move forward with the next petition. Does the petitioner for petition 2020-001 MCAB petition connection with the determination of an adequate supply wish to present?
Good morning. Hi, this is Duke Rodriguez. We did talk, I believe, to Mr. French about when the petitions were submitted. We actually wanted the purchase limits to be discussed first, because that would obviously, chicken and an egg situation would then trigger adequate supply. So if it's okay with the chairperson, would you consider changing the sequence of those last two ones so you can address first the purchase limits, then the adequate supply, since they kind of dovetail into each other?
Of course, I agree with that. Rather than discussing the 001 petition in connection with the determination of an adequate supply, I move that we now listen to the petition to raise the patient purchase limits, which is listed as the petition 2020-002. Would you like to give us your presentation?
I think she's trying to connect versus the phone. That will be Kylie Safa. Don't know if she's having a technical issue. They probably need to unmute her.
I don't show her listed as a participant. What?
This is Duke. I'll just have her come to my desk and have her speak from this line.
Okay. Thank you, Duke.
Hello, this is Kylie Safa. I'm the one who submitted the petition 002, I believe it's numbered. So I'm going to start with just a general review of some of the points in the petition, why I believe that the purchase limits should be raised. The first point is that New Mexico's limits are abnormally restrictive compared to other states with medical cannabis programs. As of right now, there are currently 35 states that have a medical cannabis program either effective now or recently passed with the last election. Of these 35 states, the ones in our region are Oklahoma, Colorado, Arizona, Nevada, and Utah. Oklahoma has a purchase limit amount of 270 ounces for the same period that New Mexico does. So let me back up for just a minute. New Mexico's purchase limits, as I'm sure most of you know, is 230 units for a 90-day period. This equates to essentially 8 ounces in the 90-day period. So I've simplified the surrounding states with a similar measurement and converted it all to ounces in a 90-day period. So Oklahoma has 270 ounces in a 90-day period. Colorado allows 180 ounces in a 90-day period. Arizona, with their medical program, allows 15 ounces in a 90-day period. And Arizona just recently passed adult use cannabis, and they're allowing 90 ounces in a 90-day period under that program. Nevada is allowing 15 ounces as well in a 90-day period. And Utah, which is generally a rather conservative state, is actually allowing 12 ounces in a 90-day period. So you can see that of all the states around us, we have the most restrictive purchase limits actually in the entire country. And as we heard from Dr. Zerlo today, we now have over 100,000 patients registered, and that does not include reciprocity. And I'll speak to reciprocity in a few minutes here as well. Let's see, the next point that I have is patient survey responses indicated a need for higher limits. So I actually submitted a petition to the Secretary of Health, Kathy Kunkel, back in 2019, March of 2019, proposing a rulemaking process to increase the purchase limits. And I've attached, you should have in the attachment, her response to me indicating that they were currently under a rulemaking process for the plant count, and she indicated that they would consider looking at the purchase limits during that rulemaking process after they received survey results. Now, unfortunately, that never happened. They did receive survey results, and surveys indicated that nearly half of the patients, when asked, would you purchase more cannabis or cannabis-derived products in a 90-day period if allowed, nearly 50%, 48% answered yes. So this indicates that nearly half of the patients would need more medicine. They need better access. And with the discrepancy between purchase limits of other medical cannabis programs, it's pretty clear that New Mexico's an outlier in this situation. And we shouldn't assume that just because of, I believe Dr. Zerlo mentioned that only 50 patients in the program have reached their limit. That doesn't mean that patients have less need for medicine than in New Mexico than in other states. we can assume that the patient acuity is comparable between the states. And what we need is to provide better access so that patients don't have to resort to other sources, like going across state lines to one of these more generous states to access the medicine that they provide that's restricted in the state of New Mexico. There's also a discrepancy between qualified patients, what qualified patients can possess. If you have a personal production license, you are allowed to, of course, purchase your 230 units or 8 ounces in a 90-day period, but you're also allowed to harvest and possess all of your cannabis from your personal grow. So that could greatly exceed the 230 units. That's currently the maximum. And so this discrepancy creates an inequality between the patients. Patients should be allowed to access the same amount of medicine. And if a patient has a greater need for medicine, they should be considered. It shouldn't be, we shouldn't treat the program to the average patient. The program should treat all patients' needs. So if there are 50 patients that require more medicine, then the limit should be increased to make sure that all patients' needs are met. And then, of course, COVID-19, we can't have this discussion without considering some of the impacts that COVID-19 has had on the mental state of people's day-to-day lives, with increased anxiety and depression. These are all factors that contribute to some of our qualifying conditions, and even some of the conditions that you just approved, like anxiety, PTSD. These are all conditions that are going to be exacerbated by the current pandemic. And in order to meet the CDC's recommendation of allowing patients to have a stockpile so that they don't have to go into the dispensaries often, we should increase the limit to make sure that they have what they need when they need it. And then I would like to circle back to reciprocity. This is an issue that Dr. Zerlo actually neglected to mention has already been discussed in the district court and ruled on. On October 9th, there was a hearing about a mandate that the Department of Health issued on September 11th, and then an emergency rule that was issued on October 8th, the evening before the court hearing on the 9th. And the Judge Wilson determined that that the rule that they are trying to promulgate now through the rulemaking process, which is essentially a copy and paste from the emergency rule that was denied, he determined that it was contrary to the statute. So the statute defines a reciprocal participant as an individual who holds a proof of authorization to participate in the medical cannabis program of another state of the United States, the District of Columbia, a territory or commonwealth of the US, or a New Mexico Indian Nation tribe or pueblo. Now, a proof of authorization, the legislature acknowledged that not all cannabis programs look the same. Some programs have a card, as New Mexico does. Some programs have a letter signed from your doctor. They don't all necessarily have a card, and the Department of Health's proposed rule is requiring a card. It's also requiring a residency or non-residency requirement. And the statute did not include any kind of residency requirement. It doesn't say that the proof of authorization has to match the participant's place of residency. It doesn't have any kind of restrictions that the department is trying to promulgate in their rule. And the courts enjoined the Department of Health from enforcing the proposed rule, the emergency rule at the time. And so I know that in the discussion, it was mentioned that this is a loophole that we're trying to close.
Excuse me, presenter, I'd like to interject here. I can appreciate the issues that you are bringing to the floor in regards to reciprocity. but I would like you to please stick with the petition requiring the raising of the patient purchase limits, please.
Okay, I thank you. I do think that the reciprocity issue ties into the raising of patient limits directly, because patients, whether they're from New Mexico or from another state, need access to their medicine. And the rule as it's currently written, 230 units in a 90-day period, is restrictive, and the most restrictive in the country, in fact. And if, you know, if New Mexico residents are having issues accessing their medicine.
Thank you. I understand that there is a rural hearing regarding this issue also upcoming on December 4. Again, please let's talk about the raising of the patient purchase limits at this time rather than the reciprocity.
Okay, well then, I believe I've presented everything from my petition. If you have any direct questions about the petition, I'd be happy to answer them.
A few thoughts that I have on this are with the potential of recreational cannabis being approved, and I do think this meeting and the next is extremely important to make sure that we're protecting the medical program, and that's been a lot of talk about that. So if we are not allowing enough patients, 50% of patients, to have access to the medicine that they need, and recreation gets approved, then I think that the credibility of the medical program is going to decrease, and patients perhaps are then going to go outside of the medical program, and we're going to lose a lot of the work that we've done is going to get lost. So with this and the next discussions, I do think that we just need to keep that in mind and making sure that we are preparing for that, what's probably coming down the pipelines. That's one thought. And the next thought is I agree, in any other medication or pharmaceutical, if a patient needs to increase dose or they need a certain amount, then it needs to become available to them. So with 50% of patients not being able to get the amount that they need, I would be in support of addressing this, and I appreciate the petition, and it makes sense to me.
Has anybody done a survey to see an estimate of what would be reasonable to go to for quantities?
My understanding from the petition that was presented is that the suggestion was to increase to 15 ounces for a 3-month supply. Is that correct?
Yes, that is correct. It's a more conservative standard compared to some of our regional neighbors.
So for the petitioner, do we know if this is enough still?
That is a great question, and I would ask that perhaps maybe the Department of Health, I know, Madam Chairperson, you had asked how they came up with a determination for the quantity for reciprocal participants. Perhaps we could ask them the same question about how they came up with the determination for medical cannabis patients in the New Mexico program, and if maybe we need to revisit that determination and see what is appropriate.
I think that for some high use patients, probably more like 15 ounces per month would be a more reasonable limit. So that would be 40, work out to 45 ounces over a 3-month period. But that's just my 2 cents.
I do agree that if, like I said, 15 ounces is the conservative limit to our neighboring states. I know that most states, especially once they have adult use, and as you mentioned, that's being considered in the next session, they typically go with an ounce per day, which would equate to 90 ounces in a 90-day period. And that would be a good limit to ensure that the cannabis program remains robust and that patients continue to have access and incentive to stay within the program.
This is Davin Quinn from UNM. Dr. Zerlo, is there any data from the New Mexico cannabis program about how many users max out their limit?
Yes, thank you, Dr. Quinn. So there's actually a couple of items with regard to this that are important to keep in mind. One of them is that when looking at surveys, quite often they're looking at what people would do if that opportunity is available. However, a large limitation also comes down to cost. So it's not just about quantity, but the cost of the product. And that's something that the program is also trying to work with the licensed nonprofit producers to lower the cost for patients. However, with the current situation, what we did do is we did a poll and a query within the database and actually discovered that only 50 patients out of the just under 100,000 that were registered as of the end of last quarter actually even hit the current limit for the program. So we are talking a very small percentage of individuals, and we don't know the circumstances for those specific individuals at this time. So there could be a lot of different reasons for them hitting that limit. But even with regard to those patients, and I'm looking up the exact number at this moment, so forgive me, but only just over 500 patients even came within 5 grams of the current limitation. And so the assertion that the current adequate supply is not enough, it actually is enough for the patients that are enrolled in the program at this time. Very few, and I mean a minuscule amount, actually even reach that potential limit that the program has now. Now, the program does have the option at the current time that patients within the program do have the option that if the 8 ounces is not enough, that they are then able to apply and get with a letter from their providing medical provider, be able to increase that limit to the 12 ounces for every 90-day period. And so there are mechanisms in place to be able to help those particular patients who have additional use. However, the bigger concern, quite frankly, is not about the amount that patients actually are purchasing, but the costs that those patients incur in purchasing that amount. And until those costs go down, I don't think we'll necessarily have a true idea of how much patients would actually use if they had it available. But at this current time, with the costs that the producers have for the product, only 50 people, again, in a 90-day period, out of just under 100,000 patients, even reach that limit. Thank you.
Thank you. And just one more follow-up question. Do we know how many people applied for the extension from 8 to 12?
I don't have the exact number on that. Dr. French, can you attest to approximately how many of those you are approving per week or per month?
Yes, approximately 10 unit increase letters are requested weekly, and so approximately 40 are approved a month. And so I would say over the past 3 months, probably 100 to 115 letters have been submitted.
Great,
For varying amounts, here's the other caveat. It's for 30 units, 60 units, 50 units, for a varying amount of access.
Great, thank you.
One thing that we know is that patients, dose themselves and use what is appropriate and do a pretty good job of self medicating the amount. And so, if we increase the amount to include those 50 patients, even though it's a small percentage, it still does show that those 50 patients plus the 40 potentially a month that are requesting increases, to me, that's a barrier that then they have to go through more paperwork and request it. Then why not have that be allowed and include those 50 patients? I don't think it means that every other patient is going to start using more medication when most patients do dose themselves. Is there any other negatives to this? And I do think one more thought is that it does tie into our next discussion. And I know we're not talking about this yet, but based on the petition for the increasing adequate supply, that, if we potentially discuss that and are able to increase adequate supply, that could bring down the cost, and therefore it would allow more patients that would want to purchase more at one time.
Dr. Goodman, so the issue there is increasing it also allows individuals who are participating not in good faith to be able to purchase more with regard to diversion. And so while completely in agreement that patients are very good at regulating their own amounts, what we have found with the purchases that are currently able to happen is that patients are able to do so within the means or within the current structure of the program with the 8 ounces, or with being able to get the additional 12 up to 12 ounces with consulting their medical provider. And again, the important part about this is really to ensure that somebody who is using higher amounts is doing so in consultation with a medical provider, and ensuring that they're not simply just using additional medication when there may be other medical issues going on which could account for the additional usage, or other therapies that are also possible that could be used in conjunction with the use of medical cannabis. And so to ensure that individuals are doing this under proper medical care, that is the reason for the limit, even though there are a few people who do reach that. Again, our recommendations from the program is that those individuals work with their medical providers to ensure that there are not other medical processes, therapies, or other solutions to the situations that they may be experiencing.
Okay, that makes sense. Thank you for that.
I would like to add a comment as well. This is Kylie Saffa again. I just want to point out again that our other states in the country and our neighboring states have all managed to increase their purchase and possession limits without having this fear of diversion that's been thrown around a few times. And I don't think it's fair to assume that patients are criminals. And I think that assuming that people are acting in bad faith just to access the program and do something illegal with it is an unfair assumption.
And just to clarify, this is not speaking to the general for patients. This is really the concern about individuals making sure that they have the appropriate medical care. Just as with any other medication, if someone is increasing their doses, that would be being done under a direction of a medical provider. And so with medical cannabis, it should be the same situation, that in order to follow those standards of care, individuals should be consulting with and receiving that advice through their medical provider. And that is the main concern with regard to this.
I can understand that.
I was going to say we might be able to quantify this if we look at the amount now, and then if we are able to keep tabs on this over the next couple years, when or if recreation is approved, are requests for increased supply increased or not, or are people needing it? Because there will be no, and I agree, it's not fair to. Thank you for those comments, to assume that the patients are criminals, and I think that's a very fair statement. I do think that you know, it would take away the issue of diversion if recreation is approved, but maintain the integrity of our program to make sure the patients are getting what they need.
And I don't know if this, I mean, I think probably the bigger issue to access, I agree, is not necessarily the purchase limit, which affects not an enormous number of people, but when I was looking through the survey, I mean, a quarter of the people who are enrolled in our program make less than $20,000 a year. And so I assume then, and that financial cost is going to be an enormous barrier. And I believe for whatever reason, the medical cannabis in New Mexico costs 3 times as much as Colorado, and from what I've heard from patients, is decidedly inferior in quality.
Variety.
I would like to comment to that. I agree that one of the huge barriers here is cost, and New Mexico has an average gram price of about $10. And while it's slowly trending downwards, Colorado has an average gram price of about $3.35. So there's obviously a huge discrepancy between the cost of medicine in New Mexico versus in Colorado, and that directly relates to supply. And supply will also hinder discovery and research into new products and product variety. So both of those issues, the cost and variety of products, can be addressed if we address the supply issue.
I think that there's a good chance that the folks who are not approaching their purchase limits are potentially not doing so because they're not able to afford the medicine, but also because the variety is not there, right? Like maybe those higher CBD strains that they need for their chronic pain or for their epilepsy, like, aren't quite as available because we don't have adequate supply in our state.
Hi, this is Davin Quinn from UNM. Strikes me that perhaps a compromise between, ensuring adequate regulation and oversight of medical cannabis use while also providing sort of increased access. I would be in favor. I would be in favor of the increase to 15 that's being proposed. So I move that we approve the petition.
I would
I'll
second
that.
Go ahead.
Yep, go ahead. Either one.
All right. So for the petition of 2020-002 for the increase of quantity limits to 15 ounces in a 90-day supply, your vote can be entered as approve, not approve, modify, or table. Ariel Bowers.
I approve.
Kenneth Graza.
I disapprove.
Jean Paul.
I approve.
Rachel.
I approve.
Courtney.
I approve.
Alan.
I approve, with one other interjection, that the availability of imported cannabis across the border is a big issue in southern part of the state, and this would probably help decrease that demand a little bit.
Devin made the motion to approve. I will enter your vote as approved. I also approve. Tracy White.
I approve.
All right. So majority has voted to approve the petition 2020-002 to increase the purchase limits to 15 ounces in a 90-day time frame. Excellent. All right, moving on now to the petition of 2020-001, the petition with determination of an adequate supply. Would you like to present at this time?
This is Duke Rodriguez. I'd like to go ahead and present. Taking it back in history, just to review with the committee some of the history, this issue has been considered before. For those of you who are new members, it was considered in October 2016 and voted in November 2016 by the Medical Cannabis Advisory Board. Just to let you know, this adequate supply is pretty much the same issue that we saw in 2016. It was approved by the committee unanimously. It was recommended to the department, and unfortunately, it was denied by the secretary in 2017. Kind of fast forwarding, here we are back in 2020, facing the same issue that we've faced for many years. For a moment, I'd like to cover just new material. If we could just recall what's the purpose of the Act 262B-2. I would like to just read it out real quickly because it's really important as to why we're having to have this conversation. Quote, "The purpose of the Lynn and Aaron Compassionate Use Act is to allow the beneficial use of medical cannabis in a regulated system." And that's an important part because that issue has been litigated quite consistently with the state. And please, we have to talk about the purpose is to allow. The statute does not say it is to restrict, it is to limit, it is to prevent, it is to prohibit, it is to put up barriers. It is to allow the beneficial use of medical cannabis in a regulated system. The department has argued over time that a regulated system gave them the authority to do pretty much what they wanted. I'd like you to know that that didn't get well received by the court, and the court says a regulated system is versus a non-regulated system simply means don't buy it on the street, buy it in a framework that is allowed and encouraged and protected. Now I want to read, fast forwarding to 2018, Judge Thompson did rule on this matter. And instead of giving you the 72-page ruling by Judge Thompson, I just want to highlight some of the facts written from his opinion, 72-page opinion. Number one, the language of the statute must prevail over the agency regulation, and the DOH may not overrule the portion of the Act that provides for an adequate supply by such a restrictive and unsupported plant count regulation. Number two, again, the plant count is for regulatory purposes only and actually defeats the purpose of the Act by restricting adequate supply. Number three, DOH's reliance on the fear of federal government intervention in the state-run program may not be the basis for its plant count limit. Number five, compared to other states, the count limit is an outdated concept. And the last one, from the opinion, I'd like to pull up real quick, is DOH impermissibly reads into the statute its style of regulation that in fact impedes on its statutory mandate to ensure an adequate supply. The basis of those statements is let's talk about where we were then and let's talk about where we are today. In 2016 and in 2018, when Judge Thompson made his ruling, the state was essentially at 70 some odd thousand cardholders and effectively 1/2 of one plant per patient. Earlier today, you heard Dr. Zolo talk about that we are at 51,000 licensed plants. If you take 51,000 licensed plants with 100,000 cardholders, today in 2020, we are again no different than we were in 2015, no different than 2016, 2017, 2018, and 2020. We are today at essentially 1/2 of 1 plant per patient. Kylie spoke about comparing ourselves to other states. Is it reasonable? Is it comparable? Does it follow the science, the knowledge of where other states are managing their programs? The evidence is very clear that it's not. If you look at programs that are smaller than ours, take Nevada. Nevada, for those of you who are not aware, has an unlimited plant count, i.e. no such plant count within statute, no such plant count within regulation. Take Colorado. Colorado does have the appearance of a plant count, but what it's allowing its medical places, unlike New Mexico at 1/2 of 1 plant per patient, Colorado is effectively today licensing 9 plants per patient. Now, this is a program with 84,000 cardholders. We are a program with 100,000 cardholders. If we were just to adopt the Colorado model, we would be licensing 900,000 plants in New Mexico just for our medical patients. So we are clearly out of line with Colorado and Nevada. Let's talk about Utah. Utah is the latest medical program, and in the first 6 months, Utah has enrolled 10,000 cardholders in 6 months. Now, the number of plants they have licensed for 10,000 cardholders is based upon a size of facility. They license 10 growers with each about 10 allowed to have 10,000, each allowed to have 100,000 square feet of cultivation. So they licensed 1 million square feet for 10,000 cardholders. That's about, for their cardholders, that's about 100,000 plants for 10,000 cardholders. And again, if they were the size in New Mexico, they would be licensing 1 million plants, much like Colorado. So it's New Mexico that remains the outlier. Let's talk about the other larger states who have very established programs, ones that we would consider robust, and certainly the federal government's aware, they've managed to succeed. Let's talk about Arizona and Oklahoma. Today, Arizona has approximately 250, 300,000 cardholders. Kylie told you about their purchase limits. They're 15 ounces or 5 ounces a month, 15 ounces over 3 months. Their plant count, for those of you who may not be aware of it, no plant cap. They allow producers to produce enough medicine to bring down the price and ensure that there's an adequate supply. Now, the single biggest, fastest growing medical program, and this is medical only, is Oklahoma. In the first year, Oklahoma has managed to take their robust medical program from essentially no cardholders to approximately 350,000 cardholders in about a year. How many plants do they allow per cardholder? Again, they have no plant cap. It's unlimited plant cap. So if you look at it, you essentially have unlimited plant cap in Oklahoma. You have unlimited plant count in Colorado. You have unlimited plant count in Nevada. You have unlimited plant count in Arizona. And you have an effectively unlimited plant count currently in Nevada. Every surrounding state, and we've had this debate, you've read the stories, you've seen the arguments, it's the same issue we've had over and over again. If you want to give patients choice, if you want to provide patients access, if you want to do all the good things that medical cannabis should do, you must recognize that the primary and central problem to our entire model is the plant count. Now, I didn't send copies to you, but I do have a recent study that was published last week in Lancet Psychiatry 2020. It was a funded NIH study. I'm glad to forward it to the committee members if it would be helpful. It basically talks about going back and doing a retrospective cohort study of 63,354 COVID-19 cases in the US. And it looked at those cases who were confirmed COVID cases. What were the implications 90 days after? And it shows that there is a 20% prevalence factor of increased psychiatric related cases. People are obviously anxious, people are feeling isolation, people are feeling depression. And you are seeing it in our increasing card enrollment. COVID has not only exacerbated demand, but it's taken it to a level that the department could not have predicted. And not only have we had a historical problem, that problem is now exponential. And if we look at the most current number of infectious cases, that problem is not going away. And the obvious
All right,
answer.
Mr. Rodriguez, thank you for your information. I understand that with the petition that had been submitted, that the
was that 10
petition
minutes?
is suggesting that we either recommend immediate suspension or substantially raising the current plant count. Is that the overall end game of your petition that is on the floor for discussion at this time?
Madam Chairman, I don't believe there was 10 minutes. I was providing new information. So I'd like to ask, why was I cut off?
I was given information that you had been speaking for 10 minutes.
Running. It was 8 minutes.
All right. I had been given information that you were speaking for 10 minutes. That's the reason for the interruption. I would be interested in having the new information submitted into evidence, and let's open it to the floor for discussion.
Are there a limited number of growers that are allowed in the state?
There are 34 licensed growers.
Possibly there should be more.
At this point, DOH is not allowing additional licensees. I think it is reasonable to have additional licensees, yes. But the real issue is the adequate supply is additional licensees means more plants. In fact, the real answer is we still need more plants today. Last time we went out for 12 new licensees, the process was started in 2014, 2015, and all 12 new licensees were not live for 2.5 years. New licensees will not resolve the problem immediately.
So thank you, Duke, for your petition and comments. I think that a lot of this makes sense to me, that this is a no-brainer. I don't see, I think we do need to catch up a little bit. I don't know why we, I agree with, if we're going to have a program, it needs to be adequate. It needs to be, enough. And some of the restrictions do seem to be a little antiquated. So I think, I was on the board, had a lot of issues. That's why we're going to see a lot of things again, of a lot of issues that we recommended were getting declined, and it was a frustrating period given our leaders in place at the time. To me, this does make sense. I think that allowing more increase in the plant count is going to increase the variety. It's going to drive down the price. It's going to create jobs. And in a time right now, I think I'm in full support of that. It will also allow us to, what we just spoke to, is to potentially learn more about how many patients actually are not receiving enough medication because of either price or other reasons.
How long does it take to start whenever there's an increase in allowable number of plants until they're matured? What's the time frame?
Now, keep in mind that the number of plants is not in statute. It's a regulation. The regulation could be altered at any time. As soon as the department issues it, they could actually issue an emergency rule this afternoon and you could start growing plants. As soon as those additional plants are deployed, there's a period of veg and there's a period of flowering. Any delay now obviously means that no sooner than probably on the average 120 days before you could harvest it. So it's always, it's beneficial to do it sooner than later, because you have 120 days before you can even see the impact of those additional plants.
Hi, this is Davin Quinn from UNM. May I ask Dr. Zerlo and Dr. French, are there reasons or rationales for keeping these limits on on production?
Certainly, Dr. Quinn, thank you. Currently, right now, as I had stated in the beginning of the meeting, there's a plant limit of approximately 59,000 or a plant count. However, we're not seeing that even being realized at this point in time. There's approximately 20,000 plants that have not been grown yet with the current plant count. And so the assertions that it's a question of the plant count, that's until we see those even approaching it. We're not talking about just 1,000 or 2,000 off from the target or even 5,000. We're talking a significant amount of plants that have not yet been grown, which have been licensed. And as far as supply, the adequate supply of what is in stock has continued to grow over the last several years, where now if you combine both the flower and bud as well as the cannabis-derived products, there were over, and mind you, this is a point in time, so for that one day, there were over 9 million units or grams available for patients to be able to have access to. Now, the other side of it is the question of variety, and on that, the department doesn't have any argument with it with regard to the fact that there does need to be more variety. Patients have requested it. We've talked with producers many times and increasing that variety. And as far as cost, also, costs definitely should be lower. And if those additional 20,000 plants were being grown, I think we would see lower costs at this point in time as well. But again, the reality is right now with the producers that we have at the moment, that they are not yet at that limit, and they're not even at, growing at the limits that we have imposed. And while other states have been mentioned during this, that is true. Many other states have different rules, different regulations. The same is true with many other industries or areas. New Mexico is unique, and we have had this program for quite a long time, and we are trying to ensure that patients do indeed get the services that they need and that they require. The biggest issue that I see occurring and where we really see patients saying that they are not having access are in the rural areas. And so the program has been encouraging the producers to serve those rural areas more frequently in much better ways. And we're seeing improvement in that area. And for that in and of itself is huge. But with regard to the plant counts themselves, we're seeing almost a third of the plants that are currently paid for and licensed not being grown every quarter.
So why is that? Because that's a huge discrepancy between what you're saying and then what the petitioner is saying. A few companies that have the capacity to grow more and they're at their capacity, and then other companies, but the extra plant count that are not being grown yet, is it companies that don't have the space or the money to grow more plants? I mean, do you know why the discrepancy?
Well, it would be different for each producer, but essentially what we really would need to look at would be each individual producer to determine, but those producers have already paid for the plants. So as far as, affordability for the plants, yes, they would have to figure out as far as the cost for growing the plants themselves, but they have already paid for those plants. And so ramping that on up, that would be the true focus at this point in time. Why the discrepancy is there, I couldn't answer, but what we do see is we see that those plants that have already been allowed for, and it's not a small amount, so it's not an amount where we could say it's only 100 or 200 per producer. We're looking at large amounts of plants here. And so with that in mind, this is not just a 1 or 2 producer situation. This is across the board. And so they already currently have the ability to produce more as a group, and we haven't seen that occur. Now, I will say in the last year, we have seen huge increases in the number of plants being grown, and so they are continually reaching towards that capacity. And so we hope that they continue to do so and actually reach that capacity this next year.
Madam Chairperson, I'd like to answer that question as a petitioner. There is a discrepancy. It's interesting that if you look at this year versus last year, You heard Dr. Zerlo earlier speak that membership is up 20% or 27% year after year. I'd like to remind you that actually activity level transactions and sales is up 65%. So there is an increased level of production, and there are some discrepancies. In the petition that you hold before you, if you look at pages 3 and 4, we make mention as to the errors in reporting. The NMDOH has had a serious problem with counting and reporting accurate data. That was determined during the trial, and it still remains a fact. Included in the numbers that Dr. Zerlo reports as 6 million grams in inventory at 12/31, upon further investigation, it was off by 3.9 million grams. And it becomes reporting errors where numbers are carried over. 100,000 got typed up as a million. When you look at the actual data, it is not very difficult to measure how many plants can be produced. And you can see that the demand is substantially higher than the number of plants. Why wouldn't producers produce more? They have full desire and intent, but there are natural barriers, capital access, zoning requirements, construction time. So there is no harm to patients, particularly in increasing the capacity, the number of license, and the number of actual plants in production. There's a natural phase-in period, and every other state around us has proven that they have effectively managed the growth with no diversion challenges from the federal government, no risk other than more products, better choices, and at a lower price.
I think I'm trying to understand, this is Ariel Bowers. I'm trying to understand if there's a good reason to have a plant count. Like, is there a good reason to have a plant count?
Sorry, I was muted. The question about is there a good reason? The Speaker of the House has called it an archaic system. The proposals for legalization remove the plant cap. Every state around us has removed a plant count. The only logical, if you want to give it any credit, has been a movement towards canopy. And where they've tried a canopy in Oregon, what they did in lieu of a plant count is allowed you to have unlimited licenses. So it effectively achieved a plant count. Plant counts are an archaic method of trying to restrict access. It goes back to the war on drugs. And to answer your question point blank, there is no logical, rational reason for a plant count to exist.
Thank you for that. Any other perspectives on that?
If we took a plant count out of the regulation, is the concern from the Department of Health that it could potentially affect the medical cannabis program moving forward? Or I want to hear the perspective from Dr. Zerlov about what his view about the need for a plant count versus getting rid of it, which is, again, something that's listed in the petition.
Thank you, Dr. Richmond. Essentially, the reasons for the plant count and the licensures from the very beginning of the program was so that the producers can be reasonably regulated to ensure that plants and product are as safe as possible, and that is the aim of the regulations. Every time there are increases with regard to the plant counts, with regard to licenses, we also have to expand the resources available to the program itself in order to ensure that there are enough regulators or inspectors to be able to go out and see and ensure that the producers are actually doing what needs to be done in order to produce safe medication. And so that would be the limiting factor at this current time with regard to that. And For example, right now the program has actually put in for a request to increase the number of inspectors or compliance officers that the program has. However, unfortunately, due to the situation with COVID, that has not yet gone through. But that would be the limitation, because anytime there's an increase in the actual production, we also need to increase the ability of making sure and ensuring that the product being produced is as safe as possible.
Madam Chairperson, Judge Thompson specifically said in his 72-page ruling, the plant count is based on regulatory needs and not based on the medical or data assessment of patient needs. What he was trying to explain is exactly what Dr. Zerlo said. Just because it's more convenient for the department doesn't mean that it's meaningful and necessary. He repeatedly tried to say there is no value in a plant count. Just because you think it's easier to count 450 versus 1750 versus blank, that's not a good reason. Whether there's a plant count or no plant count, there is still a seed to sale tracking system. Every single plant is assigned a barcode and counted and tracked. In Colorado today, in their medical program, they have actively 85,000 cardholders, and they've got in excess of 400,000 medical plans specifically just to the medical. They have another 900,000 plants committed to their adult use. But again, every single plant is tracked and recorded.
And if I may, just on one aspect of that, again, this is not a question about the plant count. It really is, was there a reason for it? And when I talk about the fact of having the regulators, having the compliance officers, this is not because it is more difficult to count the number of plants. It is about the safety aspect. It is to ensure that what is being grown is being done in a safe manner. It is making sure that when manufacturing occurs, it is done in a safe manner so that we do not have situations where plant matter or medication is being contaminated by outside sources, and or that it is not being done in such an unsafe manner as to cause injury to other individuals. That is what I talk about when I talk about it from a regulatory standpoint. And again, from a programmatic standpoint, if we do indeed, if there is an increase in the number of plants, in the number of licenses, all I am simply saying is that there also needs to be a subsequent increase in the number of compliance officers so we can ensure that there are indeed those safety regulations which are required and which need to occur in order to ensure health and safety of the patients within the program. So if it is looking at an increase in the plants, there also needs to be an increase in the resources to ensure that health and safety. And that is simply all I am stating with regard to that.
That makes sense. Thank you.
We've had plant increases in the past, correct?
That is correct. In fact, the most recent one was last year, where the plant count was established at its current levels.
Yeah. Was there a regulatory issue that arose from that process? Outside of you just needing to get more people on the ground?
That issue was decided by the courts. It wasn't as though the department wanted the plant count to go up. They attempted to keep it at 450. The court mandated that they actually raise the plant count. And in fact, they raised it to 2,500. And then they immediately came back with the revision at 1,750. So for a short period, 2,500 was apparently better than 450, but not apparently too much more than 1,750. There was the opportunity to go back to the courts, and I think there will always be that if the plant count continues to be arbitrary and capricious, I think this issue will be continued to be litigated. A plant count is probably the core of the problem. It limits access.
So
Okay,
what are the issues?
so-
What are the issues right now if we recommend to eliminate the plant count? Or are there any?
So the issue that I would state with regard to that is ensuring that there is the ability to have the compliance officers, have licensing compliance team to be large enough in order to ensure the health and safety of everybody involved, from the employees all the way to the patients.
The committee clearly has the authority to recommend eliminating the plant count. It still will be consistent with what happened in 2016. The recommendation will be forwarded to the secretary in some time. Unfortunately, it took a year plus to get the answer then, but it'll still be subject to the secretary's approval.
Yes, I understand that. So some sort of potentially, I might move to eliminate the plant count, and with a focus, if I can say this as a side note, or as a focus to do what needs to be done to ensure that the safety is there as well, that we ask commissioners to evaluate to what plants are growing safely and under the same scrutiny that we have now under a lower plant count.
I agree with that. I certainly want the safety issue to be addressed. And I don't think that is in the purview of the petition that's in front of us now. Seems like the petition that's in front of us now is to either limit the plant count, or to remove the plant count limit, or to raise the plant count limit when I look at the wording of the petition. So it seems that is really the issue to us for the board. Is that something that the board would feel comfortable moving forward? Okay, well, do you guys agree with me from looking at the petition?
Can I make a comment about the safety issue? Because the petition we submitted was strictly plant count, because the safety issue still is intact. Every 5-pound lot still must be tested. The seed to sale system must be in place. So yes, we obviously always believe, whether it's 1,000 plants or 1,000,000 plants, every test must still be preserved and continued. So we kind of stepped away and tried to narrow the argument down just to the availability, just to the adequate supply, as to the number of plants. We don't sell widgets. We don't sell doorstops. We only produce one product. And what's important, this is a product we don't import from out of state. Everything that happens in New Mexico can only be produced in New Mexico. So we limited it just to the cultivation and production of plant material in New Mexico exclusively, without addressing those other side issues.
Sure. Thank you for that. Okay, so to the board, my understanding is with this petition, again, we either are deciding whether or not to remove the plant count or increase the limit. Would you guys agree with me on that from looking at what the petition is recommending for, or suggesting to us?
Yeah, I agree.
Okay, so when we move forward with doing this kind of a vote, then just like with our other petitions, are we voting to approve it, to say, yes, we need to get rid of the plant count or increase it? Do we dismiss it? Do we modify it? Do we table it? So are you guys ready to move forward with a vote?
I'll motion to remove the plant count.
I second.
All right.
This is Davin Quinn. Can I just make a comment?
Please.
I guess I'm hearing both sides of this. I'm hearing there's a need to increase plant count, for access and variety, and to meet the demand. I also am hearing that there's a need to sort of respect kind of the regulatory requirements, as well as the infrastructure needed to do that. And so I guess I'm interested in sort of a middle path. And if the plant count was increased last year, I'm just wondering why wouldn't this be a question that would be asked every year to this committee or others? So. Like, in other words, why would we not just sort of say, okay, should we increase the plant count each year according to the perceived demand or the measured demand? For instance, if it went up 20% or 60%, you know, how much money is being spent.
I agree with this. Ken Cross. I agree with that plan.
All right, one at a time. All right. So I think those are salient points, Davin, in terms of whether or not to increase it. It doesn't seem that the petition is necessarily asking us to make that determination. It also seems like we have a lot of other ongoing discussion about this. And in the interest of time and also in thinking of being able to allow for public comment, if we still have questions regarding this, we could bring it up at our next meeting to have a further discussion. I would like to just be able to allow the public comment portion of today's meeting to also take place, and we are getting close to our end of the session. Does everyone feel comfortable with doing a vote, or shall I make a motion to table this until our next meeting? All right.
I think we should vote. There's a motion on the table to vote.
Your motion is on the table to vote?
And seconded, yes. So we'd have to either, I guess, modify or retract, or I don't know. My only, I think, what Devin is a very valid point. I guess my thought behind that is, it sounds like we're behind. If we keep increasing, we're going to continue moving behind. And you know, in the true interest I see about this is driving down the price and increasing variety. And then hopefully, if Dr. Zillow agrees, like this might create some jobs as well to have increased the department to continue to monitor the safety regulations.
I guess the only other point, thank you, Dr. Goodman, is that I would make is just that if it becomes sort of an unlimited sort of plant count, and we have to find some way to do that, a regulatory process to account for that, you know, during COVID, with a lot of sort of services not able to be sort of carried out or for various reasons, I'm just thinking that a large increase is not necessarily going to be able to be managed, which is why I guess I was proposing sort of incremental approach. So that's my only other point.
Okay, so in terms of looking at this vote, it does seem that there are lots of other questions. At this point, I make a motion that we table this petition until our next meeting so that we can move forward with being able to allow the public comment of the meeting.
I second that motion. This is Ken Carrazza.
All right. Ariel Bowers, would you approve, not approve, modify, or table?
So I'm sorry, we're voting on the motion, or we're just voting to table or not table? What are we doing right now?
My motion was to table for this petition until the next meeting, as there is ongoing conversation, and I'd like to get to the public comment section.
We can table, that's fine.
Okay. How about, and Kenneth Carrazza said yes to also table. How about John Paul? Rachel?
Table.
Okay, thank you. Rachel?
Sure.
How about Courtney?
Yes, I agree to table.
Alan,
Table.
Davin,
A vote to table.
so do I, and Tracy.
Vote to table.
Okay, thank you guys. All right, so moving forward with the rest of the agenda, I would like to make the announcement for the next Medical Cannabis Advisory Board meeting. It will be held on December 9, 2020 from 9 to 12. The meeting will be conducted via web-based platform, and a new agenda and instructions on how to join the meeting will be posted on the Medical Cannabis Program website. I would now like to open the meeting to public comment.
Madam Chair?
Yes, please.
If I may, I apologize. You had stated you would go back to the regulations.
Regulations. Also, I think I would really like to be able to hear some public comment as part of today's meeting. So I am also going to table that until our next meeting, and we can revisit the reciprocity amendments at that time as well.
Thank you.
Of course. So individuals who have pre-registered for the meeting and have requested to make a public comment will be able to comment first and should limit their speaking time to 3 minutes. I apologize for the lack of time that we have left. If you have not previously requested to make a public comment, please click on the raise hand icon if you are using a computer, or dial #3 if you're calling in by phone. The live portion of the meeting will end at about 12.
Madam Chairman, would you like us to extend the time for public comment past noon, or would you like us to get as many petitions in as we can until noon? Also, would you like to decrease the amount of time you would like to give for public comment to 2 minutes per person?
I think I would have to ask my fellow board members about their time constraints. Would everyone be open to extending the meeting until 12:30 to allow for
9 participants, just so you're aware, who have pre-registered.
Perfect. If they each had 3 minutes, we could get to about 12:30 and listen to them. Is the board able to stay on the line until 12:30 in order to hear public comment?
I'm motion to extend it to 12:30.
I will need to leave at 12:15 or so.
If you were able to stay, then
All right. I am also willing to stay. I would like to be able to give the public comment speakers 3 minutes, and we will end near 12:30.
Okay, thank you. Our first comment, Jason Barker, you have 3 minutes. Your time begins now.
Yes, I wanted to clear up something quickly with the petition for treating animals with seizures and the concern expressed about an adequate supply issue. There really isn't one there, because all the products I buy that are CBD are products that are not being sold very actively at the dispensaries. They're usually on sale, and they're usually happy to see me that I'm buying an aged inventory product. Second comment would pertain to increasing the allowable purchase limits for patients. And I hope the advisory board realizes that goes hand in hand with increasing the number of plants the producers can grow. If I, as a patient, can go out and purchase more cannabis, then that means we're going to purchase the cannabis that's out there now. But if the plants are not increased and the producers can't grow more, then we'll just sell out quicker. So we do need to stay close on that topic of increasing the plant count for the producers. Basically, what happened last year was the program catching up from the previous 4 years under the last governor. Thank you.
Thank you. Is another public comment presenter willing to give us their information at this time?
Yep. The next person on the list is Craig Michaelis. You have 3 minutes. Craig, you are unmuted. Would you like to speak?
Sorry, can you guys hear me now?
Yes.
Sorry, thank you. I just wanted to thank you guys for the time in the meeting today. I also just wanted to express some concern with the possibility of future growth with the program and the election results lately. I just haven't heard you guys talk about any of that. So like I said, it was just a little concerning. I understand there will be 2 meetings. So hopefully on the December 9th meeting, that conversation will either start or continue. But that was pretty much my concern today.
Okay, thank you, Craig.
Who is next?
The next petitioner is Kylie Safa. Duke, I unmuted you again in effort to give Kylie her 3 minutes.
Hi. I must have registered incorrectly. I thought I had registered to present my petition earlier, but apparently I'm in the public comment section. So I actually don't have anything to add at this time. Thank you.
Okay, thank you, Kylie.
Thank you.
Duke Rodriguez, you're next. Your 3 minutes will begin now.
Thank you. All I want to add is that, first of all, to thank the committee members for taking the time to participate. It's hard enough to get a quorum, so it is a positive thing, and we do appreciate your time and efforts in participating. I do also have to state for the record, you know, unfortunately, we do have a state agency that is hell-bent on making life difficult for medical cannabis patients, whether it's purchase limits, obtaining approval to be a patient, or meeting the statutory requirement of an adequate supply. You can see there's always this constant fear-mongering. I think we need to move forward and realize cannabis is a healthy alternative. Any use of cannabis is a healthy use of cannabis. And I hope going forward, this committee will look forward of finally addressing those very big issues: how you get a card, how much you can buy, and how much can be grown. We address those issues, and there's going to be a lot of good done in this state. Thank you very much.
Thank you, Duke.
Yes, thank you. Who's next?
The next person has left the meeting. Let me find Haley Salazar. Haley, you are unmuted, and your 3 minutes starts now. Haley, would you still like to speak? Okay, I'm going to move to the next person. Okay, Patricia Monahan, I'm going to unmute you. And your 3 minutes starts now.
Hello, thank you. I really want to thank the board immensely for all of you being here. I remember times when we couldn't have 3 doctors that could participate. So thank you all from the bottom of my heart very, very much. And I'm going to get to later, but thank you, Dominic Zerlo, for being here and for everything you've done. I'm going to get to you next. In a nutshell, because many of you don't know me, I want to give you my background. I am a medical cannabis patient. In fact, I was a 217th patient in February 2009. I petitioned for my conditions, which I got 3 approved, in the very first medical advisory hearing in February 2009, and then became the 217th patient. And before that, I had, as a patient, testified in front of legislative committees and did everything I can to get the Millionaire and Compassionate Use Act passed. It got passed, but did not include nausea, cachexia, wasting away. I suffer from gastroparesis, so cannabis is one and only medicine that works for me. I've had a prescription for Marinol for over 15 years, and my copay now for that's like $480 and doesn't work nearly as well. So I'm a huge advocate of medical cannabis and a patient. I'm also a lawyer, and I am chair of the cannabis law section of the State Bar in New Mexico, although I'm here simply as a patient and as an individual. I also represented one of the first 5 licensed producers in 2009 and have since 2009. My practice is almost exclusively medical cannabis law. I have co-taught for NBI, New Mexico Medical Cannabis Law, for over the past 10 years. So anyway, I'm here and I'm very involved. I'm very grateful for you guys for doing what you're doing and you being involved. And I'm very, very proud of New Mexico's medical cannabis program. And Dominic Zerlo started it. You know, I worked with him in 2009 and 10 when we were licensing the first producers, and our plant count then was 99. Do you know that New Mexico is the very first state in the nation to regulate the production and distribution of medical cannabis? We're the first ones that did it. And I think we've done an exceedingly well job. And I think we continue to, and especially will under the leadership of Dominic Zerlo. So with all that, in a nutshell,
I think we lost her. I don't show her as able to speak any longer, so hopefully she can hop back on. Our next presenter or speaker is Larry Love. Larry, you have 3 minutes and your time starts now.
Hello, everybody. You can hear me?
Yes.
Okay, great. My name is Larry Love. I'm a patient. I'm the 343rd patient, a little bit after Tricia Monahan. I'm an advocate for patients. I'm an advocate for the program. And I am an advocate for recreational cannabis as well. And this is going to get pushed through in January. And I'm very afraid of what's going to happen to our medical cannabis program. If you watch what has gone on in other recreational states that had medical cannabis, our medical cannabis programs disappear. Medical products disappear. The end users are totally different than in medical cannabis than in recreational cannabis. Medical patients need high dosage of edibles and THC oils and products. They need suppositories. They need tinctures, and they need all kinds of stuff that have disappeared in other states. A friend of mine had some colon surgery, and he was in California, where recreational cannabis has been just blown up. I couldn't find suppositories. These medical products will disappear if we don't be careful. Now, the people that are writing the recreational program, they say they're going to protect the medical cannabis program, but I haven't seen how they're going to do it, and it hasn't happened in the past. Again, the end users are different. If they're going to regulate the amounts of THC like in a candy bar where 100 milligrams is maximum for recreational, that won't work for medical cannabis patients who need to take maybe 200 milligrams a day. They shouldn't be eating 2 candy bars. We need to make sure that the people writing the recreational bills coordinate with the medical cannabis program to make sure that these products and medical patients have access to what they actually need. It's happened everywhere you look. So we have to be very, very careful. One of my fixes is that I've been talking about for a couple of years on my radio show and in public on Facebook and so forth, is to give the local producers a choice to be medical or recreational. If someone want to do both, well, then they can do both. But
Larry, you have 30 seconds left.
Okay, so that the people that the dispensaries that would choose to be medical, we know that they're going to be here for the patients. And I think that we need to protect our program. I'm really afraid it's going to go away. Thank you very much for all of your hard work, everybody.
Thanks, Larry. Our next commenter is Colin Vajosevic. Colin, you are unmuted and you have 3 minutes to speak.
Thank you. I really do appreciate your time and everyone here in the committee today. I wanted to touch back on something earlier that was said about 1 in 50 or the 50 patients that had only hit their limit in the last quarter for allowable units. I am one of those 50 patients, actually. I know that for a fact. I had applied for a unit increase over 2 years ago and it was denied by the DOH. I'm someone with epilepsy and severe seizures, so I'm not sure why my unit increase would have been denied in the first place, considering I have a lot of medical evidence of my condition and what I have to go through with it. But to me, it doesn't seem easy to get allowable increased units when you actually need it. I mean, I've got a rejection form from the DOH proving otherwise. So I really hope that there is a compassionate kind of look towards the medical patients and their needs for them knowing their own management of their conditions. My neurologist wants me to medicate PRN or as needed for my own symptom relief. I know that when I don't have capped units, I can go purchase as much cannabis as necessary to help me remain seizure-free and stable. But when the New Mexico Department of Health suddenly cuts my units, my neurologist has documented my seizure activity goes up. And that's not due to lack of medical care, that's due to lack of accessible cannabis from the New Mexico Department of Health. So some of these things I just hope people can really look at in a way that's most compassionate towards the patient and their quality of life. That's part of what this program is supposed to be here for. I am one of these patients that does run out of units. So it's not as simple as just submitting a form to the DOH and getting your units increased. I really do believe after years of working in dispensaries, I've worked up in dispensaries in Santa Fe to when we only had 3 in our entire state. Patients running out of units is only a bad thing. It hurts the patients. It sends them to the black market. I mean, it's a litany of bad things that happens when medical patients run out of these arbitrary units. So I really hope that we can just have a more compassionate view going forward towards medical patients and the assumption that a lot of us can take care of ourselves with our medical practitioner that does prescribe us medical cannabis. So I feel like some of that should be best left to the care of the patient and the prescriber, not so much the DOH, because I mean, the DOH in denying me extra units has been harmful in my case. So I really hope that I can just go to serve as one of those things that can stand out in your memory next time this is brought up in discussion. But thank you again.
30 seconds left.
Thank you. I really do appreciate everyone's time, and please stay safe out there, everyone. Thank you again.
Thank you, Cullen. That is the last person who pre-registered. If there's anyone else who would like to give a public comment in the last couple minutes, you may raise your hand. Otherwise, the comment period will be open for the next 48 hours. You may submit your comment in writing to the email medical.cannabis@state.nm.us. Looks like I have Amanda Frezzola. I will unmute you, Amanda, and you have 3 minutes to speak. Go ahead. Amanda, did you want to speak?
Yes, can you hear me now?
Yep, go ahead.
Okay, hello. I just want to just say thank you to all the speakers, of course, that have hung in there with us. Of course, in this time, we're all stuck at home in our computers. My name is Amanda Frezzola. I am at Albuquerque Integrative Medicine, a card consultant company here in Albuquerque, of course, and in southern New Mexico. I have a real concern for patients' cards, for patients particularly who are unaware that their cards actually do have an expiration of every year. Even though their card itself is valid for the 3 years, of course, pending their renewal, a lot of patients and a lot of dispensaries are unaware that this is actually a regulation within the Lynn and Aaron Compassionate Use Act. And because the Department of Health, and it's greatly appreciated that they have given extensions to patients throughout this time, because it is very difficult for patients to safely access their healthcare providers during this time. We're doing, of course, all that we can with the telemed restrictions that are in place, which we greatly appreciate, as well as other aspects that have come about and have figured out a way to be able to help these patients act safely. The issue that we're going to have is that patients' renewals are not going to change. Those cards have already been issued for the dates that are going to reflect a 3-year active in the program. And if patients are continuously missing those dates, next year's renewal is going to come no matter what. And if patients are unable to have those cards active because they don't know how they actually work, it is going to create mad chaos within the medical community. They're not going to be able to access the dispensaries they need. They are going to be pushed into black markets. They are going to be pushed out into the Colorado or Arizona markets, and it's going to be unsafe for our patients. I do urge the department to make these kinds of regulations and changes that they've made to the cards more available to patients so they understand, including educating the dispensaries on how these cards actually work, as they are in contact with these patients on a regular basis.
You have 30 seconds, Amanda.
That's all I'll leave with you today. I do hope that that this reaches the advisory group, and of course, I've had conversations with Dr. Zerlo before and Dr. French, and I do just want to make sure that the patients have the access that they need when they need it with the cards that they've been
Your
given.
time is up. Please finish your statement.
Thank you for all your help.
Thank you. I'm going to go back to Patricia Monahan. She had about 45 seconds left to comment before we lost her. So Patricia, I'm going to unmute you and you can finish your statement.
Thank you. I don't know where I got lost because I was going on and talking.
I'm sorry.
Yeah, I'm sorry too. It's my internet problems. Anyway, bottom line is a big thank you to all of you on the board and Dominic and the medical cannabis program. And I think what I was trying to say is to support what I thought Dave and Quinn from UNM had said, is that maybe incremental steps make more sense. And I think plant count shouldn't be the focus. We need more licenses. We need to diversify the program. Let manufacturers grow plants. Then you'll have more competition. And with more licenses, you'll have more competition and more jobs. That's what we want. And price will go down with more competition. Right now, they're vertically integrated. They're doing it all. And let's just have more licenses where somebody could be a grower or not. And I think that's
your time is up. Please finish your statement.
I just want to really support that in terms of patients for price, variety of product and jobs, is let's have more licenses and diversify it, not have it vertically integrated. Thank you very much again.
That's all I have for public comment.
Excellent. Thank you very much for everyone's participation today. It was a pleasure speaking and working with all of you. I look forward to our next meeting. Does anyone from the board have any final comments? Perfect. I make a motion to adjourn the meeting.
I'll second that. This is Dr. Dadam.
Excellent. Thank you very much.
Well
See you
done,
on the
Steph.
ninth.
Thank you.
Thank you.
Thank you.